professionals excel in their lives and career. It is the brainchild of Dr. Akram, who is an educationist and a healthcare professionals with years of experience across several roles in India, Malaysia, and Australia. We always, provide support to the healthcare professionals who are planning to upskill their careers and migrate to Australia and even on the other countries. We are setting the new standards by providing the preparation courses for the most advanced global healthcare exam and academically offers guidance, resources, and unwavering support. Having said that, on the screen, we have our founder and CEO, Dr. Akram, who is an esteemed clinical pharmacist, distinguished professor, and accomplished research sciences with an impressive 15 years of teaching and research experience in India, Malaysia, and Australia. And also, we are really happy to have Dr. Akram on call today with the determination to help the healthcare professionals across the globe achieving their dream career, move to abroad, settling there academically is, flourishing under the guidance of Dr. Akram. And having said that, I'll just move to the next slide. We have on screen our academic heads. Dr. Alok. Dr. Alok is a seasoned pharmacy expert with a PhD in pharmaceutical sciences and having over 14 years of professional experience. He is mainly managing all the pharmacy courses that is, being catered under academically. And also we have Dr. Dini Sharma, serving as the assistant academic head for the medical courses in academically. He is a dedicated scholar. Dr. Sharma holds the MBBS and MD degree completed in India and having an MBA from the Tulsa Southern University. So under their guidance, along with Dr. Akram's, supervision, we are flourishing and helping the healthcare professionals to migrate to different countries. And we are not only catering to pharmacy domain, there are other domains like for the medicos, for the lab technicians, physiotherapists. We are kind of, catering to all the healthcare segments. Now on screen, we have all our faculties who are dedicatedly helping the pharmacy, candidates. So we have Dr. Nishta today with us, and she will be delivering this masterclass on the topic respiratory system. And as you can see on the screen, all of them have qualified the similar set of examination. Formerly, it was known as CAPS. Now it is OPRA. So they have gone through the similar set of journey and have bringing the best experience on table and helping the healthcare professionals to plan for their OPRA examination. With that, I'll be handing over the mic to Dr. Nishta. Ma'am, over to you, and I'll help you out.
Sure. Thank you, Shohini. I hope I'm audible. Am I audible, everybody?
Yes, you are.
Great. Thank you so much. So today we're going to do an important topic from the exam perspective. It's called as respiratory system. And when we think of the respiratory system, what comes to our mind firstly? It's going to be asthma and COPD, which are the two major obstructive airway diseases. So when you think of asthma, it's important and crucial to realize what are the major factors leading to asthma, the etiology of asthma. Majorly, it is a genetic disorder. Just 1 minute, I think there's an issue with the share screen. Shohini, can you share or shall I share at my end? Shohini, can you continue sharing, please?
Shoaib, can you help here?
Yes, sir.
I hope I'm audible now.
Yes, ma'am.
Yeah.
Could you please share again? There are some network issues.
Yes. I hope till here people could hear me.
Yes, Shohini, you are audible.
Yes, Shohini. If you can just reshare the presentation screen.
Yes, I'm doing that.
Great. Thank you. All right, so I'll continue from here. We were talking about the etiology, the major triggers that lead to asthma. The first of which is genetic factors. The second would be environmental triggers like the allergens, irritants, pollutants that we are exposed to. Occupational exposure, such as working in factories where we see pollution exposure. Then respiratory infections such as RSV, respiratory syncytial virus is one such example, but there are many other respiratory infections that can lead to asthma. What are the symptoms of asthma? So when a patient presents to a doctor's clinic with asthma, majorly the symptoms are dyspnea, that is difficulty in breathing, chest tightness, and dry hacking cough. So this is a very characteristic feature of the cough that asthma patients present with. That's a dry hacking cough. Now, signs is what the doctor elicits, and symptoms is what the patient presents with. Yes. We can take the questions in the end. So what I'll do is first I'll finish with the presentation, and towards the end we'll take all the questions. All right. So what are the signs? Signs is what the doctor elicits in the clinic. So doctor will first use the stethoscope, of course, to check for the chest sounds, and wheeze on auscultation would be a very prominent feature. Cyanosis, that is a bluish discoloration in the body due to inadequate oxygen supply, due to inadequate respiration. Supraclavicular retractions. These specific retractions, that is inward movement of the neck region, would be seen just above the clavicular bone. Hyperinflated chest. So all these would be the signs and symptoms in a case of asthma. Of course, pharmacology remains the mainstay of treatment in asthma, but that's not only sufficient. Along with pharmacological therapy, it's very important to focus on non-pharmacological therapies, the supportive measures, such as educating patients on self-management, how to manage such a case of asthma, how to avoid the trigger factors. Using PEF. PEF is a peak expiratory flow monitor, which helps to tell the breathing capacity of a person suffering from asthma. And it's mainly used for home-based monitoring in severe asthma patients. Avoiding allergens and smoking, the triggers, we need to counsel the patients. And as a pharmacist, your role will be very crucial in counseling the patients. Providing oxygen to maintain a good oxygen saturation, more than 90%. COVID was a era, 2020 was a time when most of the individuals, even layman, got an understanding of how to measure oxygen saturation. So maintaining the correct oxygen saturation above 90% becomes crucial, and we can always tell the asthma patients to do a home-based monitoring using a spirometer. Correct hydration. Having adequate amount of hydration throughout the day is again a crucial non-pharmacological aspect. How do we diagnose a case of asthma? So sometimes it's symptomatically, as we discussed the symptoms and signs, but to diagnose it objectively, we require a test that's called as spirometry. Okay, so when a patient suffering from asthma comes to the doctor's cabin, there is a particular equipment called the spirometer. So this patient has to blow into a spirometer and we get the readings. What kind of readings we get, we'll be discussing that in the future slides. Then we have another investigation called as ABG. ABG is arterial blood gas analysis. So instead of collecting blood from the vein, in an ABG analysis, blood is collected from an artery. For example, we have the radial artery close to the thumb region over here. So that's a very deep-seated artery, and we have to prick through and collect blood from that artery to measure the PaO2, oxygen concentration, to measure the carbon dioxide concentration, and to measure the pH of the blood. Okay, of course, in a case of asthma, the carbon dioxide will be raised and oxygen will be lesser than normal since the patient is not breathing adequately. All right, going to the next slide, please. Okay, so I'm sure some of you all must have heard of these specific treatment guidelines for asthma, which are called as GINA guidelines, GINA. These are the recent GINA guidelines, and GINA stands for Global Initiative for Asthma Management. Now, this is a perfect strategy to manage a case of asthma, where we lay an equal emphasis on these three parameters of assessing a patient, to diagnose it as a case of asthma, to adjust the dose of the medications of the inhalers, and to review how the patient is responding to the adjusted doses. Okay, after that, we will discuss what should be the preferred controllers and preferred reliever treatments in a case of asthma. Now, in the past, we've always heard that if somebody has an attack of asthma, they should use a puff to relieve that attack. That is called as reliever therapy to subside the attack when it occurs. But then there's something called as controller therapy. Controllers are medications that are taken for long term and not only during the attack, they form a part of the preventative strategy. So if somebody is taking the controller for a good period of time and at the correct dosage to control asthma, there is a high chance that the number of attacks will reduce. Still, if a patient gets an attack in spite of using the controller, one has to always carry the reliever also, a reliever puff, to make sure that during the acute attack, that patient takes the reliever. So let's look at the controller medications or the preventative medications. To treat such a case of asthma, first we need to understand in what stage the patient is suffering from. Is it a milder case of asthma? So in those situations, we have to go for step 1 2 treatment where we use as needed low dose ICS formoterol. ICS stands for inhaled corticosteroid. ICS, inhaled corticosteroid. Along with that, inhaled corticosteroid, we use a formoterol. Formoterol, as you know, it is a LABA. It is a long-acting beta-2 agonist medication which will help with bronchodilation in a case of asthma, and ICS will help to control the inflammation. In case the patient is not responding well to such a controller, which is given SOS only as needed, then the patient is going to a step 3 approach. Here the patient is moderate, not a mild case of asthma anymore. So in such a case, the patient has to take daily low dose maintenance ICS formoterol rather than as needed. That was seen in step 1 2. Okay, in case the patient is still not responding and is getting repeated attacks in spite of low dose ICS formoterol, now this patient is going into step 4. So in step 4, the treatment strategy will be to escalate the ICS formoterol to a medium dose, of ICS formoterol. And finally, if the patient is still not responding and is getting repeated attacks in spite of medium dose, then this patient becomes a step 5 where we have to consider using a high dose ICS formoterol. And in some cases, we may even have to do a genotypic assessment where we measure the IgE levels and we can use a monoclonal antibody such as omalizumab, or we'll have to measure the interleukin 5 levels. If that is high, then use a specific anti-interleukin 5 antibody such as mepolizumab. Okay, so these are the advanced therapies, monoclonal antibodies, genotypic assessment that is reserved only for very severe cases of asthma. And most of these steps, you could see that ICS and formoterol was used as the preferred therapy. As I told you, ICS to control the inflammation and formoterol to help with bronchodilation. Why formoterol is used in specific as a controller and not salbutamol? The reason is that formoterol is a LABA, and not only is it a LABA, it has a quick onset of action as well. So it has a long duration of action, about 12 to 13 hours. And at the same time, just like salbutamol, it has a quick onset of action. The onset of action will be within 5 to 10 minutes, quickly. And in some cases, even in 2 to 4 minutes. It begins its action very, very quickly. That's why it's extremely effective, not only as a controller, but also as a reliever. In the past, we used to ask the patients to carry a salbutamol puff separately. But now, as you can see, step 3 onwards, ICS LABA is not only used as a controller, but also as a reliever. If there is a patient who is taking 2 puffs of ICS formoterol in a day as a controller, maybe at the 3rd month, this patient has got a severe attack of asthma. Nothing to worry, this patient has to use the same inhaler as a reliever. So he's taking an additional 2 to 3 puffs at that point during the attack. Okay, so the burden of carrying additional inhalers, puff, that gets reduced and the adherence to treatment becomes better. That is the reason this SMART approach, MART, maintenance of reliever using the same maintenance therapy and reliever therapy, MART, using the same inhaler for maintenance and reliever. Using ICS formoterol for maintenance as well as reliever is called as a MART therapy. And here the patient doesn't have the burden of carrying additional inhalers or separate inhaler or salbutamol or a SABA. Okay, however, in step 1 and 2, since the patient was using as needed ICS formoterol, only SOF, one can consider using SABA as a reliever if an attack happens. But in most of the steps, you can see ICS LABA is the controller as well as the reliever. Yet, if the clinician feels there is slight doubt and if the patient is not responding to ICS LABA very correctly or is not tolerating the side effects of the corticosteroids or the LABA, then there is a chance to de-escalate the dose of ICS. As you can see the other controller options, either de-escalate the dose of ICS or add other therapies like LTRAs, leukotriene receptor antagonists such as montelukast, zafirlukast, or one can even use the leukotriene antagonist or the mast cell stabilizers such as sodium chromoglycate, okay, or 5-LOX inhibitors such as xalutine. So all these alternative therapies and controllers are there in those patients who are not responding well or not tolerating the ICS LABA well. Next slide, please. Shohini, can we have? Okay. So in the previous slide, we saw the treatment of asthma in adults, those who are above 12, 13 years of age. But asthma is not only a common condition in adults, but it is also common in pediatric patients, in younger children. So in those cases, the treatment strategy is very similar, but there are just few differences. On this slide, we can see the treatment of asthma in children between 6 to 11 years of age. Step 1 will remain similar, that is low dose ICS, but instead of formoterol, we prefer SABA in children in step 1. In step 2, the controller will be ICS alone, or maybe we can add a SABA or a LABA in some cases like formoterol. In step 3, we go to the regular treatment that we saw in adults. ICS LABA, in step 4 as well, ICS LABA. Okay, so majorly the change was use of SABA in step 1 rather than using formoterol directly in step 1. And the other controller options are also very similar as the adult treatment strategy, where we use a daily low dose ICS and in step 1 and 2, or ICS LABA or ICS LTRA in step 3, 4 and 5. But in children, rather than ICS LABA, the first preferred controller will be low dose ICS LTRA, be it step 3, 4 or 5. Okay, LTRA will be preferred. Even tiotropium can be used, which is an anticholinergic drug. As you are aware, tiotropium, ipratropium are also options to cause bronchodilation, and they are reserved controller therapy options in children. Next slide, Shohini. All right, so how do we assess the patient? You had seen in the previous slide, we have to first diagnose, that is assess, then we have to start the treatment, and then we have to review the treatment. So how do we assess if the treatment is working well? There is a way to assess this at home that is called as home management, home-based assessment of asthma exacerbation. So to manage this, we use a PEF equipment. It is called as peak expiratory flow meter. Okay, peak expiratory flow meter to measure how much the patient's exhalation capacity is. Okay, so in obstructive airway diseases like asthma and COPD, majorly the exhalation is affected rather than inhalation. PEF will be a good indicator of that. If the value of PEF is less than 50% or not good, and the patient is getting repeated exacerbations, that means the patient is not responding well to therapy. Okay, if the value of PEF, as you can see in this good response, it is more than 80%, That means the patient is responding well to the inhaler therapies. The patient is responding well to the controllers and the relievers. So in such a case, mostly the patient will also not have the symptoms like wheezing and shortness of breath, and this is called as a good response patient. So here we continue the regular treatment and we reach out to the clinician only in case of a severe exacerbation or when the clinician is calling the patient for a follow-up. Okay, in case the patient is getting an incomplete response. In those scenarios, we say that the PEF, it is between 50 to 80% rather than more than 80%. That means the expiration is definitely less than normal. So in such a case, of course, we should tell the patient to get in touch with the clinician as soon as possible. In critical non-responsive cases, oral corticosteroids can also remain as an option for treatment rather than inhalational corticosteroids. Okay, so that will be the decision of the clinician. Now coming to the third column, that is poor response. That is a diagnosis if the PEF, it is less than 50% of the predicted or of the normal value. Okay, so in those situations, we categorize the patient as a poor response case. Okay, so this is a case where the patient will also have severe exacerbation episodes. Okay, in such a scenario, the patient should proceed to the emergency department as soon as possible and should not wait to assess themselves at home or should not wait for the clinician to respond. Immediately, they should rush to the emergency department. So this is how we go about the home-based monitoring of an asthma case and how we assess the exacerbation and severity. Next slide, please. Okay, so let's look at what to do in a case where a patient is getting severe asthma exacerbation and the patient presents in the ED, that is the emergency department. In such a scenario, we have several options. First of which is systemic beta agonist. As we have discussed, salbutamol, terbutaline, epinephrine, all these cause bronchodilation. But as a systemic therapy, epinephrine is a good therapy. Salbutamol is generally given as an inhaler puff. Okay, it's not. It doesn't mean that it cannot be given by an IV route or as an inhalational therapy, as a nebulizer. But epinephrine is a more preferred therapy for systemic administration. Okay, given at a concentration of 1 is to 1000 and the dose would be 0.3 to 0.5 milligram every 20 minutes for 3 doses given subcutaneously. Okay, this is for those individuals who are more than 6 years old, all the adults more than 6 years old, but sometimes we may get even younger pediatric patients who are less than 6 years old. So in those scenarios, we have to adjust the dose based on the weight of the child. Okay, so see, you can see over here, the dose is based on per kg weight. So 0.01 milligram per kg weight up to a 0.5 milligram every 20 minutes for 3 doses, which would be the maximum dose. If epinephrine is not available, then terbutaline stands as the other option, which is given at a dose of 0.25 milligram every 20 minutes for 3 doses in the adult population, given by the subcutaneous route again. Anticholinergics can also be given by the nebulizer route. Okay, if ipratropium is used, it is given at 500 microgram every 30 minutes for 3 doses. Then we assess every 2 to 4 hours how the patient is responding. Okay, it can also be given by the MDI route. MDI stands for the meter dose inhaler. Okay, when given by the MDI route, we give 4 to 8 puffs as needed and we can decide to repeat the puffs every 2 to 4 hours. Corticosteroids also remain as an option to decrease the inflammation, such as prednisone, methylprednisolone, prednisolone. All these stay as the option and they may be considered to be given in divided doses. Next slide, please. All right, then we have other medications such as inhaled beta agonists, which we already discussed. Inhaled beta agonists are the mainstay of therapy, but can be considered in the ED as well, where we can use salbutamol nebulizer. Albuterol is the same as salbutamol. We use this nebulizer given at 2.5 to 5 milligram every 20 minutes for 3 doses. Okay, and then we can decide to adjust the dose eventually based on the response of the patient. Even the puffs that we have discussed in the reliever therapy, the salbutamol puff, those can also be considered. Then we have the levoalbuterol nebulizer. This is also a beta agonist, forbuterol. All these remain as options. But in clinical practice, epinephrine, salbutamol nebulizer, and corticosteroids, these are used more commonly. Next slide, please. Okay, now let's look at the comparison of which corticosteroid to use. If corticosteroid is given systemically in the emergency department, hydrocortisone definitely has a decent anti-inflammatory strength. It's going to be 1. Mineralocorticoid effect is also present, that is 1. And its duration of action would be 8 to 12 hours. But you see prednisone has majority of the effects on the anti-inflammatory side. Okay, so in terms of anti-inflammatory, it is 4 times more as compared to hydrocortisone. And plus you see the mineralocorticoid effect that is less than 1, which is a good thing because mainly we want the corticosteroids to be acting on the inflammation. So prednisone is definitely certainly a better choice to reduce the inflammation. Same goes for methylprednisolone. You see the anti-inflammatory strength, it is almost 5 times that of hydrocortisone and slightly more than even prednisone. So it is 5, the anti-inflammatory strength, and mineralocorticoid effect is 0.5. That means there will be lesser side effects with respect to mineralocorticoids. Okay, then coming to dexamethasone, which also is very potent in terms of the anti-inflammatory strength. Next slide, please. The duration of action of most of the corticosteroids, it's 12 to 30 hours almost, but dexamethasone has a higher duration of action, stretching to more than 36 hours. Okay, now the thing is, we discussed a little bit of theoretical aspects of asthma. Now we are going to touch upon what kind of questions will be asked in OPRA. Okay, an example of which is shown in this slide. You may not be asked a direct question. A direct question is something like, what is the side effects of Montelukast? Okay, a clinical question would be framed in this way, such as a case will be given. Like a 35-year-old asthmatic patient is prescribed Montelukast. A week later, he complains of vivid dreams and mood swings. What adverse effect of Montelukast is the patient most likely experiencing? So, of course, as you can see from the case, by reading the case and the symptoms of the patient, you already get an idea that this has got to do more with CNS. And here the answer is going to be option B, neuropsychiatric symptoms. Okay, but the question can also be twisted little bit. And instead of this, the question can be a 35-year-old asthmatic patient is prescribed Montelukast. Would you like to counsel the patient on any CNS parameter? And then the options may be vivid dreams, mood swings, or maybe something like forgetfulness or 2 other options. So then in that case, you should know that vivid dreams and mood swings is one of the side effects that can be seen with Montelukast. So questions can be twisted also and may not always be the same that we are discussing, but you need to understand this is how a case-based discussion proceeds. Next slide, please. Okay, next question. I want all of you to participate and tell me what should be the answer over here. A 23-year-old male with exercise-induced asthma is prescribed albuterol as a rescue inhaler. He asks how it works. Okay, so it is your duty to counsel this patient. How will you counsel this patient? What should be the answer? Think about it. Should it be A, B, C, or D? Good. So we are getting good responses, which is option C. Of course, as we discussed, salbutamol, albuterol is a major beta-2 receptor agonist. Okay, so option C, that is, it activates beta-2 adrenergic receptors. That becomes the correct option. Next question, please. A patient with asthma is prescribed fluticasone and salmeterol. So what is fluticasone and what is salmeterol? What is this combination called? Anybody would like to say on the chat box? This is an ICS-LABA combination. Okay, ICS-LABA. Salmeterol is also a LABA, just like formoterol. It's not a SABA. So this is an ICS-LABA combination. What is the most important counseling point for this inhaler? What do you think is the answer over here? Okay, so definitely it's salmeterol, ICS, LABA. Salmeterol is not used as a reliever. Formoterol can be considered, but salmeterol is always used as a controller. So option B is out, okay? Because option B deals with a reliever medication only during acute asthmatic attack. Option B is wrong. Option C, store it in a refrigerator. As such, there is no criteria like that. Option D, shake well before use. This is also not an important counseling point. The most important counseling point is option A. That is, rinse your mouth after each use. The reason being, whenever we use an ICS, there is a high chance for a fungal infection and an immunocompromised state due to the use of ICS. That's why the patient should rinse the mouth regularly to make sure that this patient is not prone to oral candidiasis or mouth infections. Next slide, please. Next slide.
It's there, ma'am, on the screen.
Okay. A 26-year-old female presents with shortness of breath, chest tightness, and wheezing that worsens at night. Spirometry is showing you a reversible airflow obstruction after bronchodilator use. What do you think is the most likely diagnosis? Now, even if you are not sure of what should be the answer, you can, of course, rule it out. So option B and option C, both of them come under COPD and both have similar features. Okay, so definitely we don't have this thing of selecting two options. We have to select one option. Bronchiectasis also doesn't present with these features very prominently. The major feature of bronchiectasis is going to be spitting out or coughing thick viscid sputum. Okay, over here, the major indicator which tells you that this is a case of asthma, it is the word reversible. Spirometry shows a reversible airflow obstruction. Remember that in COPD, which includes chronic bronchitis and emphysema, the disease is chronic. Okay, so the disease is chronic and there is a major obstruction, which is not easily reversible and not quickly reversible. But that is not the case with asthma. Okay, so in asthma, there is a high chance that you give the reliever therapy and immediately the airflow obstruction will be relieved. Okay, so spirometry shows a reversible airflow obstruction and here the diagnosis is asthma. Next slide, please. A patient is diagnosed with mild persistent asthma. What is the drug of choice for long-term control? Okay, long-term control. Very specifically, the question says long-term control. Here, definitely option C and D is out because LTRAs and SABAs are mainly reserved as reliever therapy. Among option A and B, option A is the correct answer. For long-term control, ICS is best because in the long term, what is most debilitating is inflammation. Okay, so the better option over here will be ICS. Definitely, LABA will help to bring about bronchodilation. But for long-term control, a better option, if you have to select one among these two, it is going to be ICS because of its anti-inflammatory effect. Next question. Okay, so let's look at the major differences between asthma and COPD. Now, When we use spirometer, remember we spoke for diagnosis of asthma, we do a spirometry testing. When a patient blows into a spirometer, the exhalation, the amount of exhaled air in the first second is called as FEV1. The only thing is, we have to tell this patient that when you are blowing into the spirometer, kindly exhale forcefully. Okay, so the forced expiratory volume in 1 second, FEV1, is what we look at. Okay, the second parameter is FVC, forced vital capacity. FVC is the amount of air exhaled forcefully throughout. Okay, the total amount of air that is exhaled forcefully, and FEV1 is the forced expiratory volume in the first second. Okay, majorly 80% of FVC is FEV1. That means 80% of the expired air that is expired forcefully is exhaled in the very first second. Okay, so generally FEV1 should be a major expiratory parameter where the patient is exhaling almost 80% of the air, 80% of the volume of the air. Okay, but in a case of asthma and COPD, both of these will be reduced. FEV1 will also be reduced and FVC will also be reduced. But majorly, this is reduced more in COPD because it's irreversible. In asthma, there is a chance it will reverse, okay, with the bronchodilator. In COPD, it will take a long amount of time to reverse because it's a chronic disease. All right, so in the first diagram, you see FEV1, that is major amount of air that's exhaled in the first second, and the remaining air, FVC, that is exhaled over a period of few seconds. In asthma, definitely this is reduced. Okay, so you see normally the curve is up. In asthma, the volume is reduced. But let's look at a diagram which shows pre-bronchodilator and post-bronchodilator. When we use a bronchodilator, you can see the curves are coming closer. Okay, so post-bronchodilator therapy, you can see that this curve is very similar to your first normal curve. Okay, post-bronchodilator, this red one. Okay, and pre-bronchodilator, we saw it was reduced, the dotted line. Okay, but post-bronchodilator, there was an improvement in a case of asthma. Let's look at a case where this patient has both asthma as well as COPD. In such a case also, we will see slightly there is an improvement after using a bronchodilator. However, if it's a case of COPD purely COPD, we will see that this dotted line will remain as a dotted line. There won't be much of reversal in the post-bronchodilator FEV1 nor the FVC. Okay, so pre-bronchodilator FEV1 is reduced due to airway narrowing in asthma. And there is definitely a post-bronchodilator improvement in a case of asthma. Okay, but in COPD, we see both are affected, FEV1 and FVC, and both are reduced with very little improvement or nearly no improvement after using the bronchodilator, post-bronchodilator therapy. Okay, the criteria, we are going to come to the next slide to it. Some people are messaging percentages. We are coming to that. It's given in the next slide, which I'll be showing you. Okay, if there is no improvement, this indicates persistent irreversible obstruction and it is a case of COPD. In asthma COPD overlap syndrome, which is occurring at increasingly common rates now, it is called as ACO, asthma COPD overlap syndrome. There are features of both asthma and COPD, and there is only a partial improvement post bronchodilator therapy. Next slide, please. Okay, after this slide, after 1-2 slides, we have those percentages that some people are talking about on the chat box. We'll be coming to that. But let's go to what is COPD. COPD is chronic obstructive pulmonary disease and it includes chronic bronchitis and emphysema. How does it occur? The major trigger factors to cause COPD, they are genetic factors associated with alpha-1 antitrypsin deficiency, but this is not the most common factor. The most common factors leading to COPD are environmental triggers, occupational exposures, and smoking. Age of the patient. In elderly individuals, COPD is very common. So you saw in asthma, we kept on discussing 6 years, 6 to 11 years, because asthma is common in pediatric patients. But COPD you will not see in pediatric patients. It's majorly common in elderly individuals. And after respiratory infections also, there is a high chance of developing COPD. What are some of the symptoms of COPD? Similar to asthma, dyspnea, chest tightness, dry hacking cough. Signs will include cyanosis, okay, bluish discoloration around the body because enough oxygenated blood is not reaching. Barrel-shaped chest. So ideally, the chest expansion was easy in normal individuals. But in barrel-shaped chest, the chest becomes narrower and the ribcage shape will be changing. There would be shallow breathing and hyperinflated chest. Definitely, the airflow limitation that is there in COPD is not reversible, unlike in a case of asthma. Okay, how do we diagnose? Of course, in spirometry, we can see that the FEV1 FVC ratio, if it is less than 70%. So I told you generally FEV1 FVC ratio should be more than 80%. FEV1 is good enough in the first second. But if the ratio is less than 70%, we can say this patient is moving towards COPD. Irreversible airflow limitation. In spite of giving bronchodilator, if the FEV1 remains below 80%, that means definitely this is irreversible. ABG analysis. We discussed previously that ABG will tell us how much is the oxygen pressure in the blood and also what is the pH of the arterial blood. So ideally, PaO2 should be more than 75-80. But in a case of hypoxemia that occurs in COPD, the PaO2 is highly reduced. It is 45 to 60 mm of mercury, the partial pressure of oxygen in the blood. Similarly, the carbon dioxide will be increased. So while normal PaCO2 should have been 35 to 45, here it becomes 50 to 60. Okay, so that means this is a case of hypercapnia. Too much of carbon dioxide stored and less of oxygen because the patient is not breathing correctly. During exacerbations, there is a high risk of acute respiratory acidosis in such individuals. And of course, pharmacological therapy we will be discussing. The non-pharmacological therapy will be cessation of smoking, counseling the patient, pulmonary rehabilitation, and use of vaccines such as the pneumococcal vaccine, influenza vaccine, because a case of COPD will be more prone to other respiratory infections. Next slide. Okay, so you were telling about percentages on the chat box. So this is how we categorize a case of COPD. Okay, category C patients are those who are at risk, but they are not diagnosed with COPD because the spirometer is showing normal findings. In category 1, stage 1, this is a mild case of COPD where the FEV1 FVC ratio is less than 70%, but the FEV1 is still high. It's close to 80%, especially when we are treating this patient adequately. Okay, in such cases, we might require to treat the patient in mild cases, but more important is non-pharmacological therapy over here, like telling them, counseling them about smoking cessation and avoiding exposure to pollutants and vaccinations. Okay, so here the patient may or may not have symptoms. Now let's come to moderate. Moderate case, that is stage 2 of COPD, will be those where FEV1 FVC ratio is less than 70% and the FEV1 is drastically reduced. It is between 50 to 80%. Okay, the value is lower than usual. Ideally, it should have been more than 80%. But here it is reduced, and here the patient may or may not have symptoms again. That's why it's a moderate case. But in severe cases, definitely the ratio is reduced and FEV1 is reduced even further, less than 50% in fact. Here, mostly the patient will present with major symptoms, but sometimes the symptoms are not very prominent as well. However, on spirometer, if it is showing that the FEV1 is drastically reduced and the ratio also is reduced, we definitely diagnose this case as a case of severe COPD. And now coming to very severe, FEV1 FVC ratio is reduced below 70% like in all other stages of COPD, and FEV1 is drastically reduced, less than 30%. Along with this, there is a high risk for the patient to land up into respiratory failure. So this is a case of very severe COPD. Okay, so avoidance of risk factors important in every stage. Vaccinations to prevent further infections is important, and adding the regular treatment, which we will be discussing. What is the treatment of COPD will be discussed. Rehabilitation and physiotherapy. Even there is breath work based physiotherapy that is called as rehabilitation. That's also important. Oxygen therapy may be required if the patient is moving towards chronic respiratory failure. Next slide, please. Okay, how do we treat such a case of COPD? In the past, we used to have group A, B, C, and D for treatment of COPD, but as per the recent guidelines, anybody knows what is the name of the guidelines that are used to treat COPD? Yeah, I'm looking for some responses in the chat box. What is the guideline for COPD called? Just like for asthma, we had GINA. What guideline we have for COPD? Yeah, I've got one response that is correct. Anybody else? Yes, two responses that are correct. Okay, so these are called as gold guidelines. Right, good. So gold guidelines for COPD and GINA guidelines for bronchial asthma. This is the most recent gold guideline as per which there is no category group C and D. In the past, we used to have A, B, C, D. But now group C and D are grouped together into group E. Okay, so when a patient is group A, okay, over here, how do we categorize this patient as a group A patient? Firstly, ask for history. If the patient says that no major exacerbation, zero exacerbations in the last 1 year, or maybe one moderate exacerbation, moderate attack, which did not require hospitalization. Okay, this would be the first symptomatic criteria. The second criteria would be MMRC scale and CAT assessment tool, COPD assessment tool. So these two are scales to measure how severe the symptoms of the patient are. If the scores on these scales are on the lower side, that means the symptoms are on the milder side. Okay, so such a patient who has an MMRC score of 0 to 1 is mild, and CAT score less than 10 is a mild case. So such a patient comes under group A, and a single bronchodilator will be sufficient. That single bronchodilator can be either a LABA or a LAMA, the anticholinergics that we discuss, like ipratropium, tiotropium, or we can consider using a LABA, like formoterol. Okay, in group A, a single bronchodilator will be enough. But in case there is a patient who is saying, yeah, exacerbations were not there, however, the symptoms are slightly higher on the scale. Okay, the symptoms shown on the scale when the patient is asked questions on the MMRC scale, CAT scale, if the scores are higher, that means symptoms are high, but exacerbations are not very prominent. So such a patient will come under group B patient, and in such scenarios, we use a combination of LABA plus LAMA. Okay, nowadays we have a single inhaler therapy that is available that has both LABA and LAMA in a single inhaler rather than using a separate LABA and a separate LAMA inhaler. Okay, gold guidelines advise the single inhaler therapy because the adherence to treatment is much better. Okay, if we use a single inhaler. Then coming to group E are those cases which, irrespective of their symptom assessment on the scales, the MMRC and CAT scale, this patient is complaining of exacerbations more than or equal to 2 exacerbations in a year, or at least or one or more exacerbations that are very severe enough to lead to hospitalization. So based on these exacerbations, we categorize a patient as group E, and in group E, the treatment may be LABA plus LAMA, or if the blood eosinophil count that is high, in such cases we have to use a triple therapy, that is SITT. You know, I had recently done a research on SITT, that is single inhaler triple therapy, where we use a LABA plus LAMA plus an ICS in the same inhaler. Okay, because ICS is going to be extremely helpful to reduce the inflammation and bring down the eosinophil count. Okay, so this triple therapy remains the mainstay of treatment, especially in group E patients. Next slide, please. Okay, so let's look at some details. Management of COPD exacerbation. Bronchodilators are used for exacerbation, such as your SABAs. Even anticholinergics may be utilized, like your ipratropium, tiotropium, if the symptoms are persistent during the exacerbation attack. How do we administer? MDIs, metered dose inhalers are used. Even a combination LABA plus LAMA is available, as we discussed. Okay, and nebulization is going to be equally effective like MDI. Okay, nebulization is specially preferred for severe cases of dyspnea. Okay, because for these patients, taking an MDI will be difficult. Taking the puff, instructing the patient to open the mouth and take the puff will be a little difficult since they're getting breathless. So nebulization would be preferred in severe cases. And theophylline, nowadays we limit its use. In the past, it was used for exacerbations in COPD, but now we say there is limited evidence on its efficacy, and at the same time, it has a narrow therapeutic index. So the chances of toxicity are higher. Coming to corticosteroid use, in acute exacerbations, we consider using short courses of IV or oral corticosteroids. Among those, prednisone is used commonly, given 40 milligram orally, and we slowly taper the dose rather than stopping it suddenly. Yes, next slide. Okay, now antimicrobial therapy is another therapy that is used in COPD because such patients suffering from COPD are more prone to infections. Especially in chronic bronchitis, the sputum is very thick, thick green sputum. Sometimes there may be superadded fungal infection as well. Okay, so one has to look at the sputum sample, check for the sputum volume and purulence, and check which pathogen was there. Do a culture testing, and the pathogens can vary from H. influenza to Moraxella catarrhalis to Streptococcus pneumoniae to H. parainfluenza. There are different types of pathogens. In most of these scenarios of uncomplicated exacerbations, macrolide group of antibiotics and third generation cephalosporins are helpful because of their broad spectrum of action, since they are effective against most of the pathogens. Keep in mind that trimethoprim sulfamethoxazole combination should be avoided because of increasing pneumococcal resistance that is seen with this combination of antimicrobial. Amoxicillin and first generation cephalosporin are ineffective due to beta-lactamase susceptibility in such patients, while erythromycin, it lacks activity against H. influenza. Okay, so that's why azithromycin is preferred, and third generation cephalosporins or doxycycline. In case there is a doubt that there is a risk of Pseudomonas aeruginosa infection, okay, in Pseudomonas infection, we will see a greenish discoloration in the sputum. In those scenarios, fluoroquinolones will be helpful, and IV anti-pseudomonal agents, they can also be used. Third, fourth generation cephalosporins are also helpful. Antibiotics are typically given for 7 to 10 days, but in some cases, 5-day courses may be sufficient. And antibiotics should be started within 24 hours of detection of the infection to prevent hospitalization. Next slide, please. Okay, let's come to the questions. Please read this question by yourself because you should develop that habit of reading the questions, long cases by yourself. And what do you think should be the right answer in this case? Okay, so most of you all have answered correctly. Option B. It's not option B because we just discussed COPD. The reason option B is the correct answer is, firstly, this patient has a clear-cut exposure in a furniture factory. Okay, cough and shortness of breath, wheezing, these were also seen in asthma. But here, this patient is having it since past 3 months. So this is moving more towards a chronic case. Okay, chronic case, 3 months, furniture factory exposure, and spirometry shows an FeV1 FVC ratio of 65%. So it is reduced, it is less than 70%. Okay, in a case of asthma, FeV1 is commonly reduced, but FVC may still remain similar or the ratio may remain normal. Okay, however, FeV1 is reduced. Here, clearly the ratio is reduced. It is getting chronic more than 3 months and the patient has exposure in furniture factory. That is why the most likely diagnosis is COPD. Option B, which is the correct answer, as most of you all have answered correctly. Next slide, please. Okay, so this is a 65-year-old male taking ipratropium for COPD, complaining of dry mouth and difficulty urinating. What do you think is the most likely cause of these symptoms? What is the most likely cause? Okay, so I'm getting all the correct responses. It is going to be option B, that is anticholinergic effect of ipratropium. As you know, these are anticholinergic medications like tiotropium, and these dry mouth and difficulty urinating are prominent anticholinergic side effects seen with these medications. So here option B stands as the correct answer. Next question, please. A 60-year-old male on theophylline for COPD develops nausea, vomiting, and tremors. What do you think is the most likely cause for such a scenario? What is the most likely cause? Yes, good. Most of you all have answered correctly again. It is going to be theophylline toxicity. Like I told you, theophylline is one such medication which has a narrow therapeutic index. Okay, so such patients are very prone to toxicity, nausea, vomiting, and tremors. Tremors being a prominent and peculiar feature of theophylline toxicity. So the correct answer is option B. Very good, students. So you're following the format of clinical questions well. Next slide, please. A patient with COPD exacerbation is treated with a medication called as roflumilast. What is the primary mechanism of action of roflumilast? What is the mechanism of action of roflumilast? It is a recent evidence-based medication that is used in clinical practice nowadays in COPD. Okay, in the past, we did not have roflumilast. It was just anticholinergics, LABAs, and ICS. But nowadays, there is this new medication, roflumilast, which acts as an inhibitor of phosphodiesterase 4. Okay, so inhibition of phosphodiesterase 4 will have both of the effects. Firstly, it will cause bronchodilation, and secondly, it will also reduce the inflammation. So the correct answer over here is going to be option B, inhibition of phosphodiesterase 4. Next question. A 50-year-old patient with COPD has ABG, results showing a pH of 7.3, PaCO2 55, and PaO2 65. What do these results indicate? Okay, so I have just got 1-2 responses that are correct till now. Yeah, few more responses coming in. Good. Okay, so definitely this is acidosis. Why is this acidosis? Because normally the blood pH is supposed to be between 7.35 to 7.45. Okay, this is different from the pH that we check in the lab using litmus paper. Over there, 7 was the neutral pH. But in our blood, the neutral pH is 7.35 to 7.45. Okay, that's the normal pH. If it's lesser than 7.35, definitely this is a case of acidosis, acidotic pH. Okay, now looking at PaCO2, PaCO2 is 55. We already discussed that ideally PaCO2 in the blood should be 35 to 45. Okay, so the CO2 is elevated and PaO2, which should be ideally 75, 80, is lesser. So it's a case of hypoxemia and hypercapnia. That means it's respiratory acidosis. Okay, definitely hypoxia and hypercapnia have got to do with respiration rather than metabolic conditions. So here option B stands as the correct answer, that is respiratory acidosis. Next slide, please. Read this question. Tell me what should be the answer. Clearly, this becomes an easy indicator because spirometry shows a reduction in the ratio pointing towards COPD. And at the same time, even if you have slightest of the doubt, still you will select COPD over asthma because this patient has a barrel-shaped chest, which is seen only in COPD, not in asthma. Okay, so here the answer will be A, chronic obstructive pulmonary disease. Next slide. All right, so this is the answer key. All the answers that we discussed are written on this key. And I believe we are towards the end of the presentation. Sohini, next slide. I think there's just a thank you and some things from your end.
Right.
So yeah, in case you want to open the floor for questions, I leave it to you, Sohini.
Okay. So before I open up the forum for Q&A, there are two things I would like to highlight. The study abroad program, we have recently launched this segment to ensure you guys get the quick guidance about the unique courses and the research options available across globe. And I would request all of you to scan this QR code from your mobile device and join the channel for the latest updates regarding the study abroad program by Academically. And keeping the screen for 1 minute so that you guys can scan and join our channel. Guys, I request all of you to join this particular channel. It will help you to know about the latest trends and the posts that we will be posting in terms of our study abroad segment. Followed by, I am taking you guys now to join our WhatsApp channel for all the latest updates regarding the healthcare professional domains. You can scan this particular QR code and join us. With that, I am opening up the forum for a quick Q&A. By the time you can join as well, and you can ask your question one by one. Arindam, I hope you will be taking up the Q&A.
I mean, showing you ask, I mean, the candidate can ask to me or Dr. Nishta
Sure.
or Arindam also is here.
Sure, sir. Okay. So I'll just call out the name first. Okay. Shiva, you can unmute and ask your question. Shiva Kollipada. Do you have any question? You can ask it now. Okay. Sajid Sheikh, you have raised your hand. You can ask your question. Sajid.
Sohini, there's a question in the chat box related to OPRA. Probably you can take that.
Sure, I'll check. Not sure at my end. I'm not able to see any message as of.
Dr. Alok also is here, so the guys can ask. So there's one question basically, if I do masters in GMP, during that gives the OPRA exam, that can I practice? Yes. So while you are studying GMP in Australia, it's connected by the UTS in Sydney, right? And while you are studying there, you can appear in this OPRA exam and you can register as a pharmacist. Even we can help you to get your admission done in GMP also or a preparation as well. So please connect to us. और कोई क्वेश्चन है क्या? आई थिंक देयर एक ही क्वेश्चन था और कोई क्वेश्चन में दिखाई नहीं दे रहा.
नहीं सर, कोई और क्वेश्चन तो दिखाई नहीं दे रहा है अभी. साजिद, आपने आपका क्वेश्चन नहीं पूछा. If you want to ask anything, please do it now. Okay, I'll go ahead with the next candidate, Naseem Khan. Naseem, you can ask your question. Naseem?
I think
Joel, I
they
think not able to unmute.
I think ये अनम्यूट कर पा रहे हैं नहीं कर पा रहे हैं. Can you please check? Sure.
Yes, sir.
You can unmute Naseem Khan.
Please unmute yourself.
There are some questions coming in the chat box. 3 more questions have come.
Okay. I think ये लोग अनम्यूट नहीं कर पा रहे हैं. शोएब तुम देखो उसको. And can we get notes from your side for preparation? Yes, we provide live classes. Then we also recorded classes we provide, and study materials and mock tests for practice. Each and everything we provide. This is a 3 to 4 month course. We will cover A to Z regarding this OPRA exam. How hard or easy is OPRA is compared to CAPS, and is the scoring done, and how many months study needed? Yes, 3 to 4 month study is needed, and the difficulty level of the OPRA and CAPS is the same, but they are going to ask more clinical questions. That's why we added here Dr. Nishta. She is one of the medical doctor. Generally, आप देखोगे कि जो pharmacist को pharmacist ही पढ़ाता है, not the medical doctor. That's why we added here, because अराउंड 60% क्वेश्चन जो है अभी फार्माकोथेरेपी क्लिनिकल फार्माकोलॉजी से पूछे जाएंगे जो है ओपरा के अंदर.
Sir, what is the clearance?
If you want to add something.
Clinical perspective, it will be important to look into that. Like we discussed, the questions are not very direct, not a one-liner question. You will be given cases. Based on that case, you have to understand, you have to diagnose, look at the symptoms, and then look at the treatment. So clinical orientation is crucial in that aspect. Yes.
Hello, excuse me.
Yes, ma'am.
So can I ask my question?
Yes, please.
How much is the course fee, sir?
Actually, you need to attend a OPRA scholarship test, and based on your marks in that test, we will give you the discount on the course. Okay, or maybe show it your scholarship test. You can paste in the this
Sure, sir.
in the chat box. This is a free
Sure, sir.
scholarship test, guys. You can appear in the test, and our team will get back to you. Okay, based on your mark, we will provide you the scholarship.
Without the scholarship, usually how much the course is?
It's just 3,200, and you may get up to 50% off.
And then do we have any installment basis payment?
Yes. You can pay in installment. Even we have a loan facility. as well. So guys, हमें ये स्कॉलरशिप का टैग दिया हुआ है लिंक में यहाँ पर चैट बॉक्स में. You can go and attend. This is a free test, और this is basically mock test from the OPRA. तो जैसे क्वेश्चन आने वाले हैं OPRA के अंदर, ये उसी की बेस पे बनाए गए, तो जो आपको फ्री में जो है आपको मिल जाएगा.
Usually how long the study hours go?
So we provide weekly 10 hours in a week live classes.
Guys, if you're not, guys, if you're not speaking, please be on mute.
जो क्वेश्चन कर रहा है वही
Confused, sir.
म्यूट करो, रेस्ट को म्यूट कर दो. यस. ओके.
difference
नीतू, कैन यू प्लीज रिपीट योर क्वेश्चन?
सर कैप्स एंड ओपरा में डिफरेंस क्या है?
पहले जो थे कैप्स में 2 पेपर हुआ करते थे, पेपर 1 पेपर 2, एंड दे डिवाइडेड इनटू लाइक तो 51 मार्क्स रिक्वायर्ड थे पास करने में. बट यहाँ पर ओनली 1 पेपर होगा, 120 क्वेश्चंस एंड 2.5 आवर टाइम, and they are going to ask a little bit more a question from the clinical background based questions, clinical case based scenarios. Just name change किया, थोड़ा सा सिलेबस को जो है मॉडिफाई कर दिया है, और नथिंग मच चेंज, सेम प्रोसेस
सर
है.
ओपरा देनी पड़ती है ना रजिस्टर्ड फार्मासिस्ट बनने के लिए यूएस में?
It is not for US, it is for Australia.
हाँ
ऑस्ट्रेलिया
ऑस्ट्रेलिया
में.
के लिए हाँ रजिस्टर्ड फार्मेसी के लिए ओपरा देनी पड़ेगी.
यस.
सर मेरा एक और क्वेश्चन था. मैंने बीफार्म किया है इंडिया में से. ओके एंड जस्ट रिसेंटली पास आउट. तो मुझे अब क्या करना चाहिए? लाइक ये एग्जाम क्लियर करनी चाहिए या फिर एक और ऑप्शन है मैं वहां जाके एमफार्म करूं तो मुझे कोई अनदर एग्जाम देनी पड़ेगी?
नहीं, हम आपको you is up to you, you can go for M.Pharm. M.Pharm में हम आपका एडमिशन करा देंगे. जिस
मतलब सर एमफार्म देने के बाद कोई एग्जाम देनी
कोई
नहीं
एग्जाम
पड़ती?
नहीं देना पड़ेगा. Basically you are skipping only the OPRA. Once you pass OPRA exam, now you are equivalent to your Australian pharmacy graduates. Means M.Pharm अगर आप ऑस्ट्रेलिया से भी करते हो तो अभी आपको 1 साल का इंटर्नशिप करना पड़ेगा, उसमें रिटन और ओरल जो एग्जाम होता है वो भी आपको भी देना पड़ेगा. बट OPRA एग्जाम आपको नहीं पास करना होगा.
ओके सर तो वो एग्जाम का नाम क्या है?
कोई एग्जाम नहीं देना आपको अभी, वो 2 साल के बाद की बात है कौन सा एग्जाम देना है. अभी इफ यू आर गोइंग फॉर मास्टर ऑफ फार्मेसी, नो एग्जाम रिक्वायर्ड.
ओके सर थैंक यू.
Thank you. So guys, if you want to study any course from Australia or anywhere in the world, we can help you in that. Also,
Next, let's start.
if you want to join OPRA, I know, so our team will call you back. They will call you back one-on-one. So you can also ask to them, if you have any question, all those things, and they will guide you.
Sir, I have a question.
Yes. So, Shivani, can you take one by one name?
Yes, sir. Yes. Guys, you can raise your hand. I'll just call out your name.
Kunan Ali. Mohammad Fahim Hassan.
Mohammad Fahim, you can ask your question now. Okay, next we have Rika
Mohammad
Rashmi.
Fahim, Ritika. Samir, Arun.
I just want.
हेलो
Hello.
Yes, Ritika.
मैम, मेरे क्वेश्चन ये है कि जैसे ओपरा एग्जाम की प्रिपरेशन के लिए टोटल फीस क्या है इंडिया में?
अरे भाई तो बताया तुमको अभी, यू कैन रीड द चैट. मैंने बताया था कि एडमिशन का फीस होता है अराउंड 1600 इफ यू कैन पास. तो आपको एक हमने लिंक दिया हुआ है, ये जो है चैट बॉक्स में, इसको जाकर अटेंड कर लो, ठीक है. एंड जस्ट वेट, आवर टीम विल गेट बैक टू यू. वो आपको कोई स्कॉलरशिप देंगे और आपको अराउंड 17,000 रुपये देने पड़ेंगे.
ठीक है सर, थैंक
यू.
हेलो.
यस अरुण.
सर जैसे हम अगर स्टडी वीजा पे जाते हैं फार्मेसी के बेस पे ऑस्ट्रेलिया, तो वहाँ पे एज अ फार्मेसी असिस्टेंट जॉब कर सकते हैं ऑस्ट्रेलिया के अंदर?
यस, कर सकते हो. फार्मेसी असिस्टेंट के लिए कोई भी लाइसेंस रिक्वायर्ड नहीं होता है. बट द बेस्ट ये रहता है, यू कैन स्टार्ट योर प्रिपरेशन नाउ ओपरा का, एंड यू कैन ट्राई टू पास इन इंडिया. अगर आप इंडिया में नहीं कर पाते तो आप डायरेक्टली चले जाओ स्टडी वीजा पे ऑस्ट्रेलिया के अंदर, और वहां जाके पास कर लो ओपरा एग्जाम. तो आपको इंटर्नशिप मिल जाएगा, आप पार्ट टाइम इंटर्नशिप कर सकते हो. और इफ यू आर गोइंग फॉर मास्टर ऑफ फार्मेसी, still you can work as a pharmacy assistant also.
ओके सर, थैंक यू. और सर जो ये एग्जाम आप प्रिपरेशन करा रहे हो ओपरा की, ये कितने महीने की प्रिपरेशन है?
4 month की, including the revision. 3 to 4 months total.
और सर कौन कौन से ईयर मंथ्स में होता है इसका एग्जाम ओपरा का?
मार्च, जुलाई एंड नवंबर।
ओके सर।
Hello.
Yes, guys. Next.
Hello.
Hello, sir. I
Yes,
just
Ritika,
want to
please.
ask.
Yes,
I just
Ritika.
want to ask, like, I have completed my PharmD in 2024. Now, from when can I start the preparation? Like,
Oh, this is the right time for you if you already finish your PharmD. So, are you
yeah,
currently working?
yeah, currently working.
Where?
I'm currently working at staffing.
No, are you working as like clinical pharmacist or hospital pharmacist, retail pharmacist? क्या job है आपका?
No, this is totally of different one. Not in the hospital. I'm working in the some
IT job kind of.
company. Yeah, IT.
Pharmacovigilance.
Yeah, IT.
Okay. So yes, this is the right time for you to start preparation. Simultaneously, please work in the hospital pharmacy or retail pharmacy because once you pass the exam in your letter, once you pass the exam, Hospital Pharmacy Council will give you a letter. Okay. So in that letter, they mention that okay, you are eligible to apply for retail pharmacist or hospital pharmacist. तो इन दो डोमेन में आप जॉब करेंगे, it will be very helpful to you to get a job and PR visa also in Australia. Okay, Ratika?
अस्सलामुअलैकुम सर।
Yes, Anaya.
सर मैं पूछना चाह रही थी कि हमें ओपरा एग्जाम के लिए एलिजिबल होने के लिए कितनी CGPA वैलिड है? मैं पाकिस्तान से हूँ तो हमारी
I understood. ठीक है, इसमें they don't see any CGPA और marks और percentage आपने कितने थे. They just want to see you just need आप डिग्री आपको मिल गई, आप पास कर गए हैं डिग्री. Even if you fail in your pharmaceutical subject में और आपने बाद में क्लियर किया वो सब्जेक्ट तो भी कोई प्रॉब्लम नहीं है. फाइनल डिग्री अगर आपको मिल गया है, प्लस यू मस्ट बी ए रजिस्टर्ड फार्मासिस्ट इन योर होम कंट्री. दिस इज द ओनली रिक्वायरमेंट. CGPA नहीं देखते हैं इसके अंदर.
ओके सर, थैंक यू सर.
Thank you.
Sir, when is your next batch starting?
This is, I think, this week only going to start new batch because last week ही एग्जाम हो गया था जो है ओपरा का. तो दिस वीक ही स्टार्ट हो रहा है, इसीलिए हमने ये आज जो है एक लाइव सेशन किया आपके साथ में. तो गाइस उधर वांट टू ज्वाइन दिस वीक में जो है, मतलब अपकमिंग वीक, बिकॉज आज संडे है तो मंडे से जो ये वाले वीक में एक न्यू बैच स्टार्ट हो रहा है ओपरा का. ठीक है, तो उसमें आपको बिल्कुल जीरो से आप स्टार्ट करेंगे.
Hi sir.
Yes,
sir, is there any age requirement for this exam?
Yes. So to write this exam, there is no age requirement. I mean, whether you are 50, 60, even you can write the exam. But to get visa, your age must below 45 years. ठीक है, 45 साल से आपका एज कम होना चाहिए, 45 years से आपका एज कम होना चाहिए टू अप्लाई द वीजा. नो तो फिर एज अराउंड 42 तक अगर आपका एज हो गया, 43 तक, तो आप यू कैन टेक द रिस्क. आई मीन यू कैन राइट द एग्जाम. उसके बाद अगर 44, 45 है, देन नॉट रिकमेंडेड फॉर यू.
Okay. Sir, this you're charging the amount, right? In that this visa process is also included, or?
We are a edtech company. We are providing here the coaching, not the anything else. Okay, but we guide the student, and for visa we will provide you the lawyer from Sydney. You need to pay the fees for the lawyer separately. So we are not a visa agency. We are a healthcare edtech company. So our job to help you to clear the exam and give you the right resources, right guidance, how you can register as a pharmacist, how you can practice here, how you can get a job and visa, all those things.
Okay. You will be giving the mock exams as well, right?
Yes. We provide a free live classes and we provide study material and we will take long exercise mock. All those things we provide.
Okay, thank you, sir.
Sir, good afternoon. I'm
Yes,
Ritika. Sir, I'm a pharmacy fifth year. Now I'm going to internship. So I should go in hospital pharmacy, retail pharmacy. Not in like pharmacovigilance.
Yes. So please, if you want to work in abroad, whether it is Australia or Ireland or any country, Okay, so please start working once you complete your PharmD in India. Start working in any hospital pharmacy or any retail pharmacy. Okay, and simultaneously you can prepare any of these exams, whether it is OPRA or PSI for Ireland or whatever you want to practice. Okay, so this will help you. You can apply for a retail pharmacist job. You can apply for a hospital pharmacist job. Since you already have
After,
some experience.
after completing my OPRA exam, in which I will get like a hospital pharmacy or retail pharmacy based
Both,
on.
both. You are eligible for to apply both jobs.
Okay, sir.
Yeah, once you pass this exam, Australian Pharmacy Council will issue a letter. This letter we call skill assessment letter. Okay, and in that they mention two occupations. One is called retail pharmacist, another is the hospital pharmacist, and you are eligible to apply for visa for both occupations, and you are also eligible to practice in Australia as a retail pharmacist or as a hospital pharmacist. Okay.
Sir, I have 5 years of experience in pharmacovigilance. So will that be any issue?
Pharmacovigilance experience they won't count. This is if you are working any other field, they need practicing pharmacists, licensed pharmacists. Means if you are working in retail pharmacy, hospital pharmacy, that experience they will count. If you are working in pharmacovigilance, clinical research, medical writing, medical affairs, ऐसी कोई भी job अगर आप कर रहे हैं, these experience वो count नहीं करते.
Okay. Otherwise, they will consider me as a fresher.
Yes.
Okay. Thank you.
सर ओपरा के लिए फी क्या रहेगी?
मैंने अभी बताया था आपको, it can go to around 70 to 80,000 Indian rupees if you are from India, but you need to attend this free test. Okay, ये OPRA का हमने ये लिंक दिया हुआ है, उसको जाकर आप अटेंड कर लो, बस 1 घंटे का है, एंड यू विल नो कि आपको कितने क्वेश्चन आते हैं, आप कितने मतलब आपको कैसा प्रिपरेशन भी है, तो उसको जाकर आप अटेंड करो और आवर टीम विल गेट बैक टू यू. आज ही आपसे कनेक्ट करेंगे एंड दे विल गाइड यू फर्दर. यू कैन लिस्ट आउट योर क्वेश्चन इफ यू आर नॉट एबल टू आस्क. यहाँ पर आप अपने क्वेश्चन को लिख के रख लो. अब हमारी टीम में जब कॉल करेंगे तो आप उनसे रिसीव करते हो 1-on-1 एंड दे विल गाइड यू ईच एंड एवरीथिंग.
सर आफ्टर कंप्लीटिंग OPRA एग्जाम व्हाट इज द नेक्स्ट?
प्लीज वन बाय वन.
अकरम सर सैलरी किसमें ज्यादा मिलती है, हॉस्पिटल ओपीडी फार्मासिस्ट या रिटेल फार्मासिस्ट?
सेम ही रहती है. ऑस्ट्रेलिया में आपको मिल गया लाइसेंस फार्मासिस्ट का एंड यू विल गेटिंग पेड पर आवर बेसिस. तो जनरली हॉस्पिटल में जो होती है गवर्नमेंट जॉब्स होती है और रिटेल में जो प्राइवेट जॉब होती है. So, if you want to earn more money, you can go into the retail pharmacy because you can work more hours.
Thank you, sir.
Are only classes okay, or do we need to do self-study as well?
No. Whatever we are providing, this is A to Z, and we will cover the syllabus. But your job to revise the content. एग्जाम में तो आप ही को बैठना है, हम तो पूरा पढ़ा देंगे, राइट? वो जितना पढ़ाया गया आपको, you need to revise the content. आपको बाहर से पढ़ने की बुक नहीं बोलते हैं. Each and everything we will cover A to Z.
Thank you, sir.
हेलो सर.
Yes, Soumya.
हाँ सर मैं ओडिशा से बिलोंग करती हूँ.
Okay.
और 23 में मेरा बीफार्म खत्म हो गया है. उसके बाद मैं 1 ईयर का इंटर्नशिप कर रही थी एज ए हॉस्पिटल फार्मासिस्ट.
ओके.
तो सर ये ओपरा एग्जाम क्या होता है कुछ मालूम नहीं है, तो शॉर्टली क्या मेरे को आप बता सकते हैं?
यस. तो बेसिकली किसी ने अगर इंडिया से कोई भी फार्मेसी का डिग्री किया हुआ है, ओके, तो इफ यू वांट टू वर्क इन अब्रॉड, किसी भी कंट्री में अगर आपको अब्रॉड में जाकर जॉब करना होगा, देन यू नीड टू राइट द एग्जाम उस कंट्री का. ओके, तो ये ओपरा एग्जाम होता है ऑस्ट्रेलिया एंड न्यूजीलैंड के लिए. अगर आपको यहाँ पे जाके अगर एज ए फार्मासिस्ट जॉब करना है तो आपको ये एग्जाम लिखना होता है ऑपरा. तो हर कंट्री का अपना एग्जाम है. PSI एग्जाम होता है फॉर एग्जाम्पल फॉर आयरलैंड, PBC एग्जाम फॉर कनाडा, DH एग्जाम फॉर दुबई, SPL एग्जाम फॉर सऊदी अरबिया. तो से ये जो ऑपरा एग्जाम है ये होता है ऑस्ट्रेलिया न्यूजीलैंड में आपको रजिस्ट्रेशन करने के लिए एज ए फार्मासिस्ट. ओके, और इट इज ऑनलाइन एग्जाम यू कैन गिव इन इंडिया. देयर इज 8 to 10 एग्जाम सेंटर्स हैं यहाँ पे. आपको इंडिया में ही एग्जाम ये ऑनलाइन एग्जाम देना होगा.
ओके सर, थैंक यू.
Okay, thank you so much.
Sir, how many hours of study is needed per day?
Please one by one. Yes, Hardik, please.
Hello.
Please one by one. Please unmute.
हेलो सर.
Yes, Hardik.
हेलो सर. सर मैं साजिद अली बोल रहा हूँ MP मध्य प्रदेश से. जी सर, मैं पूछना चाह रहा था ओपरा के लिए पहले PT एग्जाम देना पड़ेगा या डायरेक्ट ओपरा?
यस, So to become a registered pharmacist in Australia, you no need to write, before English. English आप बाद में दे सकते हो, English का टेस्ट, PT या OET या IELTS का टेस्ट देना होगा आपको, वो आप पहले दे लो या बाद में दे लो, इस कोई ऐसा प्रॉब्लम नहीं है।
जी जी सर, एक्चुअली मेरे क्या है कि PT मैंने जो है क्लासेस ज्वाइन की थी और उसमें फर्स्ट इंस्टॉलमेंट मैंने जो है पे किया था और क्लास कंटिन्यू थी, और कुछ इशू के कारण जो है मैं वापस कंटिन्यू नहीं कर पाया।
तो आप कंटिन्यू करना चाहते हो, यू कैन डू नाउ।
जी हाँ,
ठीक है। तो अरिंदम, ये साजिद का ये केस है, इनको अलग से कनेक्ट करा देना आप।
हेलो सर।
यस
हाँ सर, एक्चुअली मैं न्यूजीलैंड रेसिडेंट हूँ और मैंने वहाँ पे
प्लीज वन बाय वन कुछ सुनाई नहीं दे रहा है,
हेलो।
यस दिव्या।
हाँ सर, मैं न्यूजीलैंड रेसिडेंट हूँ और मैंने एक बार कैप्स एग्जाम दिया था वहाँ पे, तो वो ऑस्ट्रेलियन फार्मेसी काउंसिल से जो रजिस्ट्रेशन वो सब करवाना रहता है वो कराया और एग्जाम दिया कैप्स का, पर वो क्लियर नहीं हो गया। तो अभी मुझे ओपरा देना है, तो वो सब रजिस्ट्रेशन वापस करना पड़ेगा क्या?
नहीं, अगर आपका असेसमेंट पहले हो गया था तो वो असेसमेंट सेम ही रहेगा। नाउ यू कैन बुक फॉर ओपरा एग्जाम फॉर जुलाई। ओके दिव्या।
Good afternoon, sir.
Yes, good afternoon.
Good afternoon, sir.
Good afternoon.
Yes, my name is.
Just please continue.
Okay. My name is Sheikh Yusuf, and I am from Africa, and I have been following your colleagues for some time.
Okay.
So I want to write the OPRA exams, but I'm having a small issue, which I have discussed with your colleague also. The main issue is that I am not having an active registration certificate, and which the APC asks to get either a completion certificate or a registration or an endorsement letter. So I wrote to APC to confirm if they are going to allow me to write the OPRA exam with the endorsement letter, because I am not eligible to register as a pharmacist in India.
Yes. So in your case, you need to provide two letters. One letter is called endorsement letter you already have, and another one you need to show you are a registered pharmacist in your home country. Since you are not an Indian citizen, you cannot register in India as a pharmacist. So you already got that endorsement letter, but you must show you are working as a pharmacist, you are registered pharmacist in your home country in Africa. Okay.
There is another thing. Sorry, sir. The thing is, if I'm going back to my home country, it will take me at least 2 years to obtain the registration certificate. So I was trying to bypass the years. Yes. So I was trying to confirm if the registration certificate is really necessary,
You can
or I
write
can proceed with endorsement.
You can write the email to APC directly and can ask.
Okay, sir. Thank you, sir.
Okay, thank you.
Sir, how many hours studies needed per?
Hello. Please one by one. तो मैं नाम बोलता हूँ आपका,
Hello.
Sudha Rani, can you please unmute? Guys, I will take your name, then one by one फिर आप unmute करने जब आपका नाम आता है. Sudha Rani, can you please unmute? And Ume Maria.
Good afternoon, sir.
Good afternoon.
Yes, Ume Maria, can you please unmute? Or Sudha Rani. Paramjeet Kaur.
Good afternoon, sir.
Good afternoon.
Sir, I'm currently in PharmD 5th year now. So I want to write a OPRA exam. So can I start preparation from now only? And what all skills do I need along with this preparation?
Okay. So you just started your 5th year, or you are going to appear in your 6th year?
Like if I start preparation like from now onward.
So in your 5th year near to completion, or going to start your 5th year?
Started, sir, 5th year.
Okay, so it's too early. It's little early for you. you can join when you are doing your internship. That's the right time for you.
Okay, sir. So, sir, can I start preparation, sir, for
Yes,
this?
you can. Our team will get back to you and they will guide you further. Okay.
Okay, sir.
Okay.
And sir,
Thank.
along with this, do I need any skills? Like
We
many
will
courses
we will
are
guide you.
going on.
I mean, you just need basically the to work in any retail pharmacy, hospital pharmacy, if you can, as a part time. Now, since you are a student,
Yeah.
yeah. So then you will learn the skills here. To
Okay,
join
sir.
any retail pharmacy, especially like Apollo Pharmacy or any retail pharmacy nearby your home. Okay.
Okay, sir.
Yeah.
Okay, sir.
Okay.
Thank you,
Thank
sir.
you. Uh, Sudha Rani, can you please unmute? Or Paramjeet?
Hi, sir. I just would like to know
Hello,
about
sir.
like scoring
Yes.
method, like how to score in the opera. Do we need to pass 50% or
Opera
what the rank?
will, this is the this is a, rest methodology they are using. So they are not anything mentioned that how much percentage you need.
Okay.
But we are just assuming because they just copy from this exam. Earlier they conduct AMC exam, Australian Medical Council exam. So in
Okay.
that there is a scale called 0 to 500 and 250 unit to score. तो 50% मार्क्स इसलिए रिक्वायर्ड होते हैं AMC के अंदर. तो हम एज्यूम
Okay.
करें यहाँ पर भी वही होगा, पर इन्होंने कहीं मेंशन नहीं किया हुआ ये कितने परसेंटेज रहेगा. So this is like a individualized test. Okay, so some questions they will give you for 1 mark, some maybe 2 mark question, some maybe 3 mark question. Depends the difficulty level of question and how many you are given the correct answers.
Okay, sir. Sir, one more question. Like I have a lot of gap in my study because I did my bachelor in 2010. So is all right? Like, did you think I can cope or it's a bit
Yes,
hard for?
yes. I mean there is a one lady I can give you the best example.
Okay.
Her age is 43.
All right.
And basically she connected to me earlier because she want कि मेरी बेटी का एडमिशन करा दो आप ऑस्ट्रेलिया में सर और मैं उस पर डिपेंडेंट चली जाऊंगी तो
Okay, sir.
उनकी एज था 43 का. उन्होंने ये एग्जाम क्लियर कर लिया, उनको पीआर वीजा भी मिल गया है.
Okay, sir.
फ्रॉम केरला तो अभी तो आप इतना टाइम नहीं हुआ आपको, यू कैन.
Okay. Thank you, sir. Thank you.
थैंक यू. परमजीत के बाद यस सुधा रानी, कैन यू प्लीज अनम्यूट?
Hello, sir.
यस हाय.
Hello.
Yes, hello. Yes, Sudhani, can you please continue your question?
Hello.
Yes, hello. Can you hear me? Okay, Vikramjeet, can you please unmute?
Hello.
Yes, Vikramjeet.
Yes, I am a government pharmacist in West Bengal.
Okay.
So I'm practicing since 3 years. So
Okay.
my interest is to appear in OPRA.
Okay, very
So
good.
am I eligible?
Yes, you are.
So is there any requirement what I have to take from something?
No. I mean, at this moment, no any requirement. When you are applying the visa, you may ask to your employer. I know. अभी कुछ करने की जरूरत नहीं है आपको. You just need to start your.
Yeah, because I'm employed in government. So yes,
अभी कोई ऐसा रिक्वायरमेंट नहीं है, ठीक है. You can start your process. But when you are applying the visa, once you got invitation, उस टाइम पे आपको गवर्नमेंट से आपको रेजिग्नेशन देना होगा.
What's name when the sound?
Okay. And
Okay.
Do I have to appear in IELTS or something?
Yes. Both exam is mandatory. OPRA plus English test. तो IAS या OET कोई भी टेस्ट होगा उसका प्रिपरेशन भी हम लोग कराएंगे. तो नो नीड टू वरी. We will provide you the coaching for OPRA plus English also.
Okay. Surely I'll be going for it, sir.
Okay,
So,
Vikram.
thank you, sir.
Thank you. And yes, Sudhani, can you please ask now?
Hello, sir.
Hi, Anam.
Sir, I want to introduce you myself. I graduated in 2023, and
Okay.
since then I worked as a clinical and oncology pharmacist for almost 10 months. And after that, I have been working as an industrial pharmacist for like almost an year. would you suggest that I shall continue working in hospital or retail pharmacy? Other than
So,
working in Australia, shall I continue my job as an industrial pharmacist?
industrial pharmacy, how many years you are working?
I've been working since 2 years. I graduated in 2023, or
Okay,
I
no
have worked
problem.
as a clinical pharmacist for like almost 10 months since then. Or uske baad I joined an
I mean,
industry and
you have both options. You can migrate as a industrial pharmacist. We can help you for that. Even you can migrate as a pharmacist. And for that, you need to pass his OPRA exam. But इंडस्ट्री में जॉब थोड़ा कम होती हैं एज कम्पेयर टू फार्मासिस्ट में बहुत ज़्यादा जॉब्स आपको मिल जाएगा.
ask if I want to like pursue my career as an industrial pharmacist, what shall I do? Shall I just go for a simple skill assessment or shall
Yes.
I appear in the OPRA exam?
Basically, only skill assessment होता है plus English, then you can apply for as an industrial pharmacist.
As an industrial pharmacist.
Yes.
Okay, sir, and I wanted to ask you one more thing. I have applied for like spouse visa in Australia, so likely, inshallah, I will be getting my PR. So I wanted to ask, what would be the job aspects over there in regard to my status as a PR holder over
You know, अगर आप ओपरा कर लेते हो तो आपको बेटर रहेगा, you know, since you are already getting, you know, the PR. तो आप ओपरा कर लोगे तो you can work as a hospital pharmacist, clinical pharmacist, retail pharmacist, बहुत jobs होती हैं. इंडस्ट्री में इतना जॉब्स अवेलेबल नहीं रहता है, इसीलिए safer side, if you can pass the OPRA exam, definitely there is a high chance to work. Okay.
Okay, thank you.
Thank you. Yes, Sudhanani, I think your network is not stable. Maybe you can. Okay, next is next please.
Hello, sir.
Yes, 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 Yasin.
Hello, sir. Hello, sir.
Hello. Yes, Yasin.
Sir, yes, sir. मैं फार्म डे 4th ईयर सर रनिंग. सर ओपरा के लिए तो बी फार्म का स्टूडेंट भी एलिजिबल है सर, फार्म डी का स्टूडेंट भी एलिजिबल है सर, लेकिन ऑस्ट्रेलिया में सर सैलरी का कुछ डिफरेंट है कि सेम है सर?
नहीं नहीं नहीं, ये इंडिया के लिए ये सब है. ऑस्ट्रेलिया में बोथ आर इक्वल, सेम सैलरी मिलेगा. सेम सैलरी बढ़ता है based on your experience, on your skills, not based on your degree.
Yes, sir. Okay, sir.
Okay.
Hello.
Next is
Sir.
Hello.
Hello.
Yes.
Hello.
Please. Yes, one by one.
Sir, this side Safi Azam from Jaipur, sir.
Okay, Safi.
सर मेरा सवाल था कि सर मैं एज अ मेडिकल रिप्रेजेंटेटिव जॉब कर रहा हूँ लास्ट 5 ईयर से. बट मेरे पास जो है ना सर, मेरा जो फार्मासिस्ट का लाइसेंस है वो मैंने किसी को प्रोवाइड कर रखा है रिटेल फार्मेसी पे. तो क्या वो रिटेल फार्मेसी वाला एक्सपेंस चलेगा क्या सर, मैं अगर वहां से बनवाता हूँ तो जहाँ मैंने अपना डिग्री लगा रखा है?
नहीं चलेगा.
नहीं
दो
चलेगा
नंबर
बोला सर.
नहीं चलती है. You know, you are paying the ITR, you are filing only for one job, not 2 jobs.
ओके, बट वहां सर हमारा पीएफ अकाउंट नहीं ना है सर, तो फिर कैसे होगा?
पीएफ अकाउंट हो नहीं हो, आपके जितना इनकम है यूनिट टू शो. अगर आप वहाँ जॉब कर रहे हो वहाँ रिटेल फार्मेसी पे भी, तो आप दोनों को करा के अपने सीए से वो फाइल कराओ.
ओके.
Sir, how many hours of study is needed?
Hello.
Yes, Safi, you just wait. Our team will get back to you. Next, please.
Hello. Sir, कितने घंटे की study required है हर रोज?
At least if you can study 4 hours per day for 4 months, you can clear this exam.
Sir?
Yes.
Sir,
Yes,
you told this exam consists of clinical questions more, no, sir?
Yes, 60% questions
What
from.
kind? Sir, if you work in the hospital pharmacy in India, that knowledge is enough for clinical parts, sir?
Not just, you know, that you also need, you know, theoretical knowledge as well. Practical knowledge that definitely will help you.
Okay, sir. Okay, sir. Thank you.
Okay, thank you.
So, can you work as a trainee pharmacist in Australia?
Trainee pharmacist you can after OPRA only. This is a 1 year internship. It is a trainee pharmacist job only.
Hello, sir.
Yes. Guys, I am here for, as long as you ask the question, so please one by one आप question करते जाओ और मैं आपके आंसर करते जाऊंगा. One by one करते जाओ.
Hello, sir.
Yes.
For the assistant pharmacist, we need to appear for the OPRA exam.
असिस्टेंट फार्मासिस्ट कोई जॉब नहीं होती है यार. वीजा तुम पे होगा ही तो तुमको कौन जॉब देगा वो. If you already have a visa, you are in Australia, whether you are in study visa or any other visa, in that case you can work as an assistant pharmacist. But आप इंडिया में बैठे हुए तो तुमको कोई जॉब नहीं मिलने वाला assistant pharmacist.
Okay, one more, sir. They will provide the accommodation also.
तुमको 5 लाख रुपए देने का accommodation क्यों देंगे भाई? You need to find your own job, Guys, I mean, don't ask these stupid questions because wherever you want to work in abroad, even if you can think about, I am from UP. If I got a job in Tamil Nadu, and I need to go to Tamil Nadu and find a job and find my own accommodation, my food, and all those things, right? The same for in abroad also. Same. Once you got the job and go there, and we will guide you, but you need to find your own accommodation on your own food. Employer will not give you all those things.
Okay, sir.
Sir, after completing the OPRA, what is the next procedure?
Yeah,
Next
once you
step, what is the
pass
next
the
step?
OPRA exam, you need to apply. It's called EOI, Expression of Interest for your visa. You will say to government, I already passed this exam. I am retail pharmacist, hospital pharmacist. I want to work there. So you need to see what are the states that are open. And you need to apply EOI and get the visa. And simultaneously, you also need to apply for the APRA for your registration as a pharmacist.
So we don't have to intern.
Yes, intern you need to work 1 year. उसके बाद.
Hello, Assalamualaikum.
Yes,
Hello, sir.
Hello.
Yes, Salam. Yes,
Hello, sir. Good afternoon.
Hello.
Soumya Rani, can you please unmute? Soumya.
Yes, sir.
Shobha.
Yes, sir.
Yes, Shobha Rani, please ask. Do you have any question? Okay, Shobha.
Hello, sir. Hello, sir. Can I ask you a question?
Samir Khan, I'm just taking the names one by one.
Hello,
Shobha
sir.
or Samir Khan.
Hello, sir.
Yes. Hello.
Sir, good afternoon.
हेलो
Samir, yes, good afternoon.
सर मेरे क्वेश्चन ये है जैसे मैं आईलेट्स कर रहा हूँ तो उसके साथ में मैं ओपरा की प्रिपरेशन भी कर सकता हूँ.
यस यार ये तो आपको टाइम मैनेज करना आपके हाथ में है ना. आप दोनों
तो
को दोनों पढ़ लो अगर आप मैनेज कर पाते हो. अदरवाइज बेस्ट ये रहता है कि एक पे फोकस करो, एक को पास करो, फिर दूसरे पे आप जाओ. बट इफ यू हैव टाइम, इफ यू कैन मैनेज, तो टुगेदर यू कैन IELTS प्लस ओपरा.
सर एक्सपीरियंस के बिना दोनों एग्जाम भी दे सकते हैं क्या?
यस.
Hello, sir. This is
Sir,
Zara.
hello.
Zara, can you please continue question?
सर एक्सपीरियंस के बिना ओपरा दे सकते हैं?
One guys.
Hello.
Zara, please ask your question.
Sir, my question is that मेरा 4th ईयर है अभी पाकिस्तान में, तो मुझे सजेशन चाहिए कि क्या करना चाहिए क्योंकि मैंने लाजमी पास करना है.
यस, तो अभी तो आपको कुछ नहीं करना है, अभी तो आपको अपनी पढ़ाई पर ध्यान देना है. एंड व्हेन यू आर इन योर फाइनल ईयर, ओके, जब आप 5th ईयर में पहुंच जाओ, देन यू कैन स्टार्ट योर प्रिपरेशन विद अस इन ओपरा की. एंड वंस यू पास, यू नीड टू स्टार्ट वर्किंग इन एनी रिटेल फार्मेसी और एनी हॉस्पिटल फार्मेसी. यहाँ वो आपको 10,000 रुपए दे या 15,000 रुपए दे, यू नीड एक्सपीरियंस. ओके, आप
सर अभी भी कर सकते हैं इंटर्नशिप कोई? और ये इंटर्नशिप हॉस्पिटल में करनी है या किसी फार्मेसी पे करनी है?
हॉस्पिटल में और रिटेल में कहीं भी कर सकते हो, दोनों जगह काउंट होता है.
थैंक यू सो मच सर.
यस शोभा,
सर मिनिमम एलिजिबिलिटी क्या है, मतलब कितने साल?
बैचलर ऑफ फार्मेसी चाहिए. आप मस्ट बी रजिस्टर्ड फार्मासिस्ट. दिस इज द ओनली रिक्वायरमेंट टू सिट इन दिस एग्जाम.
हेलो सर.
यस दीवान.
सर मिनिमम एक्सपीरियंस कितना चाहिए?
कोई एक्सपीरियंस नहीं चाहिए, बट यहाँ क्या होता है, वंस यू पास देयर विल बी अ कंपटीशन अमंग द ऑल द फार्मासिस्ट. तो जिसको जितना ज्यादा एक्सपीरियंस होगा वो उसको जाकर ज्यादा देंगे प्रेफरेंस. ओके, एक्सपीरियंस
मतलब ओपेरा देने के लिए कोई भी एक्सपीरियंस नहीं चाहिए?
यस, ऑपरा के लिए एक्सपीरियंस नहीं चाहिए, बट व्हेन यू आर लुकिंग ए जॉब, तो जो आपको जॉब देगा, जो फार्मेसी ऑनर, वो दे विल सी कि कितना एक्सपीरियंस है आपको, ऑल दोस थिंग्स।
Excuse me, sir.
यस
हेलो सर। और मैं ये पूछना चाह रहा था कि कौन से सब्जेक्ट्स हैं जो कि मैन फोकस करने चाहिए ओपरा टेस्ट के लिए?
फार्माकोलॉजी एंड फार्माकोथेरेपी एंड कैलकुलेशंस, स्टैटिस्टिक्स।
सर ये डोजेज फॉर्म वगैरह?
यस।
और फार्माकोलॉजी?
यार तुम सुन नहीं रहे हो, क्या है फार्माकोलॉजी, क्लिनिकल फार्माकोलॉजी, फार्माकोथेरेपी, ये सब सेपरेट पढ़ रहे हैं। एंड यू कैन गो गाइड टू आवर वेबसाइट, वहाँ पर हमने पूरा सिलेबस दिया हुआ है। हमने बहुत सारे academically.com पे आप जाएंगे, वहाँ बहुत सारे ब्लॉग नग लिखे हुए हैं, कौन कौन सी बुक पढ़नी, कौन कौन से चैप्टर पढ़ने, क्या पढ़ना है क्या नहीं पढ़ना, आप वहाँ देख सकते हो, ठीक है। और बट इफ यू ज्वाइन एकेडमिकली का जो कोर्स अगर आप बाय करते हैं, तो उसमें जो है आपको हम A to Z प्रिपरेशन कराएंगे। So you will able to pass this exam within 2 to 4 months.
सर आप कोई प्रैक्टिस टेस्ट वगैरह नहीं देते स्टूडेंट्स को, जो हम ऑनलाइन घर में करें अब प्रिपरेशन के लिए?
ये लिंक 20 बार तो मैंने लिंक शेयर कर दिया होगा। अभी आपने ज्वाइन किया है क्या?
जी जी।
तो 20 बार शेयर कर चुके हैं हम लिंक, अपने चैट बॉक्स में जाकर उसको अटेंड करो। फ्री टेस्ट है वहाँ पर, ठीक है।
ठीक है सर, थैंक यू सर।
बहुत सारे मॉक टेस्ट आपको मिल जाते हैं एकेडमिकली पे, तो यू कैन गो एंड हैव अ लुक।
Hello, sir.
Hello, Nawab.
Yeah. So my question is, when we submit our initial application, they just ask us for about the degree, ID, and there is another thing which is letter of eligibility, some kind of, just wait, let me check. It is letter proving your eligibility to start the registration process in your country of training. So what do we need to upload?
You must be a registered pharmacist in your home country. That letter, if you can add, that's it.
So what if we upload our how would you say, the license category?
Are you a registered pharmacist?
Yes.
Yes, वही letter लगाना है यार.
Okay sir.
Same letter.
Okay sir.
Next,
okay,
please.
Hello. Hello.
Yes, hello, Shobha.
Sir, I am having a query, sir.
Okay.
That is, if we got around as a fresher pharmacist in Australia, if we got around $50,000 per year, it's in and around 50,000. Does it comes around tax slab, sir?
Yes, obviously. Government, why you need to pay the taxes in Australia according to the government rules. So whatever you are earning, whether it is 50K or 80K, generally pharmacists earn on an average 80 to 100K Australian dollar per year.
Okay, that's okay. But thing is, in India, we see that persons who are having a annual income more than 5 lakhs, they only have to pay tax like that. Is there any system like that in Australia also? That's what I'm asking.
But if it is a 5 lakh, it's going to less than 9,000 Australian dollar. If you are selling 9,000, obviously you are no need to pay the tax. But if you are earning 50,000, means you are making 30 lakh rupees. And 30 lakh, if you are earning in India, obviously you need to pay the 40% tax. Similarly, in Australia, you need to pay the tax. So generally the taxation, I think you need to check. But I think less than, if you have 20K or something, then no need to pay any tax. But if you have more than that, you need to pay the according to the tax.
Okay, it's around. Do you have any idea? It's around how much percentage?
No, it's purely based on the family, how many members you have, how many you are earning, how many dependents you have, and a lot of things is there involved in the taxation.
Okay. And one more thing, sir. You said that there is no minimum pass mark, cutoff mark, and then how we will come to know whether we had given the test in right manner or not?
They will see the system is a called crash methodology. Okay, they will know where you are. If you pass, they will give you. Means if you are attending the difficulty level 5, there is a easy question, mediocre question, or tough questions. So system will see to how many questions you attend the tough question, how many you give the correct answer, whether you are eligible to practice in Australia or not. You know, so they will see, system will see.
Hope it is not having any negative marks.
No negative marking.
Okay.
Any foreign exam, whether it is for Australia or any other country, no negative marking.
Okay. And sir, for coaching and examination fee, how much it will cost, sir, in Indian rupees?
You need to take a test, okay? Attend a test. We provide up to 50% scholarship, and after that, it may get around 70 to 80,000 Indian rupees.
सर मैं ये पूछना सर मैं ये पूछना चाह रहा था, अगर कोई स्टूडेंट डिस्क्वालीफाइड करता है टेस्ट को, तो फिर उसको दोबारा रजिस्ट्रेशन करवानी होगी?
नहीं, दोबारा एग्जाम की फीस दे करके यू कैन राइट द एग्जाम।
ठीक सर, ये पाकिस्तानी रुपीस में कितने बनते हैं?
अरे कैलकुलेट कर ले भाई, क्यों यार, मैं पाकिस्तानी में कितने बनते हैं, नेपाली में कितने बनते हैं, मैं कहाँ कैलकुलेशन करूंगा? ऑस्ट्रेलियन डॉलर होते हैं $2190, वो आप चेक करो अपने गूगल पे जाके कितने रुपए बनेंगे।
ठीक है सर।
गाइस प्लीज थोड़ा सा, यू आर गोइंग टू वर्क इन ऑस्ट्रेलिया, ये कोई लेबर का जॉब नहीं करने जा रही, यू आर ए फार्मासिस्ट, राइट? तो थोड़ा रिसर्च खुद का भी करो और थोड़ा दिमाग भी लगाओ वहां पर, ये बेसिक वाले क्वेश्चन मत करोगे यार, सैलरी कितनी होती है, टैक्स कितना है, कि ये क्या करूंगा ना। आप कहीं भी जाओ, एनीवेयर इन द वर्ल्ड, आपको टैक्सेशन देना ही पड़ेगा, एक्सेप्ट मिडिल ईस्ट। मिडिल ईस्ट में सैलरी नहीं होती है, मिडिल ईस्ट में सैलरी होती है 1.5 लाख, यहाँ सैलरी है 4 से 5 लाख, तो ऑब्वियसली यू नीड टू पे द टैक्स। एजुकेशन इज फ्री फॉर योर किड्स, healthcare is free, there is a lot of benefits to work in Australia and New Zealand. Okay, so think in that way, and all those things you can do your own research as well, and before you join. Yes, Prashant, can you please unmute?
afternoon sir.
Yes, good afternoon.
सर मेरा एम.फार्म कंप्लीट हो गया फार्मास्यूटिकल केमिस्ट्री से, सर मैं पीएचडी करना चाहता हूँ, ओपरा देने के बाद कर सकता हूँ?
हाँ, वो कर सकते हो पीएचडी। आप इफ यू वांट टू डू हायर स्टडीज यू कैन डू ऑलवेज।
सर उसके लिए क्या आगे कोई प्रोसेस है कि उसी एग्जाम पे हो जाएगा?
ये आपने कहाँ से किया एम.फार्म?
सर मास्टर ऑफ फार्मेसी इन फार्मास्यूटिकल केमिस्ट्री सर।
कौन सा कॉलेज, कौन सा है आपका भाई, कॉलेज बताओ?
सर डॉक्टर एपीजे अब्दुल कलाम टेक्निकल यूनिवर्सिटी।
अरे ये तो यूनिवर्सिटी कॉलेज बता भाई, कॉलेज मैं जानना चाहता हूँ कौन से कॉलेज से हो, आई वांट टू नो।
सर बाबू बनारसी दास यूनिवर्सिटी से बी.फार्म।
तुम्हारी यूनिवर्सिटी का इतना अच्छा नाम है, फैकल्टी से पूछ लो थोड़ा बहुत, तो आप यहाँ हमारा अभी टाइम वेस्ट कर रहे हो। इतना अच्छा यूनिवर्सिटी है आपका बाबू बनारसी दास लखनऊ में, राइट? तो इफ एनीवन वांट टू डू पीएचडी इन अब्रॉड, नॉट इन जस्ट इन ऑस्ट्रेलिया, so you must have some publication, some research experience अगर आपको है, then you can apply, and you need find a professor in the university and उनको आप email करो, अगर उनको अच्छा लगेगा आपका CV, then they will say you can apply for PhD, okay? और PhD ऐसे नहीं मिलती, हर एक को नहीं मिलती है PhD। PhD if you GPAT qualified, आपने अच्छी तरह से M.Pharm किया and you have good publications, then there is a good chance to get a scholarship and to do PhD.
Thank you, sir.
Thank you.
Hello, sir.
Yes, hello.
I am PharmD 5th year students. I want to go to Australia. तो which course लेके जाना अच्छा है या एग्जाम के एंट्रेंस एग्जाम देके?
कहाँ से हो, आंध्रा या कहाँ से हो?
I am from India, Ahmedabad.
अहमदाबाद, ओके, वेरी गुड। यस, तो बेस्ट ये रहेगा, हम आपका एडमिशन करा देंगे एंड साइमल्टेनियसली इफ यू कैन क्लियर दिस ओपरा एग्जाम, तो आपको जॉब मिलना बहुत इजी रहेगा।
ओके, अगर कोर्स लेके जाएंगे तो एग्जाम स्किप हो जाएगी ओपरा?
अगर आप एम.फार्म करने जाते हो तो स्किप हो जाएगी, बट इफ यू आर डूइंग एनी अदर कोर्स लाइक मास्टर ऑफ पब्लिक हेल्थ या जीएमपी या क्लिनिकल रिसर्च या बायोटेक्नोलॉजी, ऐसा कोई कोर्स करेंगे तो फिर आपको देना पड़ेगा।
ओके, और एम.फार्म में कौन सा कोर्स अच्छा रहेगा?
अब एम.फार्म ही कोर्स है, किसी भी यूनिवर्सिटी बस पूछो। अब इंडिया में आप एम.फार्म फॉर एग्जांपल सारी यूनिवर्सिटी में सेम रहेगा, बिकॉज रेगुलेटेड बाय द पीसीआई, राइट? तो ऐसे ही एम.फार्म आप कहीं से भी करोगे ऑस्ट्रेलिया में तो आपको ऑपरा देना पड़ेगा एंड उसमें एडमिशन हम आपका करा देंगे, सो यू कैन गेट बैक टू अस वंस यू पास योर डिग्री। ओके
ओके, डन, थैंक यू।
थैंक यू। एंड प्रथम गर्ग, कैन यू प्लीज अनम्यूट?
Hello, sir.
Hello.
Sir, I have given my PT exam and I am working as a pharmacist in a Punjab government.
कितना है आपका?
सर 90 है स्कोर मेरा।
वेरी गुड, एक्सीलेंट। यस
यस सर। तो सर मेरे यहाँ पे 75 पॉइंट्स बन रहे हैं विदाउट स्टेट नॉमिनेशन।
तो बहुत बहुत ही गुड पॉइंट है। आई कैन से यू विल गेट डेफिनेटली एंड ट्राई टू पास दिस एग्जाम एसएप। 75 प्लस 15 होते हैं, कितने होते हैं? 90 होते हैं ना?
90 होते हैं सर 491 के लिए।
Yes, मैंने बताया था, इफ यू फॉलो मी इन माय यूट्यूब, लास्ट वीक
यस
जो वीजा मिला था वो 85 वालों को मिला था वेस्टर्न ऑस्ट्रेलिया से। ओके,
यस सर।
तो आपको मिल जाएगा।
सर और अगर ऑनशोर फायदा है आने का या फिर ऑफशोर से अप्लाई करूं, क्योंकि
आप
सारी
offshore
स्टेट।
से भी मिल सकता है आपको, यू नो, यू हैव अ वेरी गुड पॉइंट एंड यू हैव एक्सपीरियंस आल्सो।
ओके सर। सर
ओके,
और
बट
मैं ये सोच रहा था कि अगर वेट से करवा के फार्मेसी टेक्नीशियन भी अप्लाई करूं तो
मुझे
करवा
आवाज नहीं आ
कर
रही,
सकता हूं।
मुझे आवाज नहीं आ रही। हाँ, क्या कह रहे?
सर अगर वेट से स्किल असेसमेंट करवा के फार्मेसी टेक्नीशियन का भी अप्लाई करूं तो उसमें फायदा है?
फायदा कुछ नहीं है उसमें जाने का, कोई वेस्ट ऑफ टाइम, वेस्ट ऑफ मनी है उसमें, नो, जॉब भी नहीं मिल पाती वहां जाके, डिफिकल्ट रहेगा बहुत। शॉर्टकट की जगह जो बेस्ट रूट है उसी पे जाओ। ओपरा, यू आर फार्मासिस्ट ऑलरेडी, आप इंडिया में, वहाँ फार्मासिस्ट आप बनेंगे।
यस सर, यस सर। ओके सर, ओके सर, थैंक यू सर,
ओके,
थैंक यू
थैंक
वेरी
यू। एंड नेक्स्ट प्लीज, अक्षय कुमार, मोहम्मद शोएब।
हेलो, नमस्ते सर।
नमस्ते अक्षय।
सर मैं ये कह रहा हूँ, मैं अभी डिप्लोमा इन फार्मेसी कंप्लीट किया हूँ, अपोलो फार्मेसी में जॉब कर रहा हूँ
अच्छा
लखनऊ में एयरपोर्ट पे। तो
अच्छा।
सर मुझे 2 साल का एक्सपीरियंस लेने के बाद दुबई जाना है सर।
यस,
तो उसके लिए क्या
डीएचए।
करनी होगी?
यस, आपको डीएचए एग्जाम लिखना होगा। जब आपका 2 साल का हो जाए
जी सर।
तो फिर आप यू कैन राइट दिस फार्मेसी, जो टेक्नीशियन होते हैं उसका एग्जाम आप लिख सकते हो दुबई के लिए, डीएचए का।
ओके सर, थैंक यू सो मच सर।
थैंक यू अक्षय। यस, मोहम्मद शोएब और समीर खान।
अस्सलाम वालेकुम सर।
यस, मोहम्मद शोएब।
सर मेरा सवाल ये है कि ओपरा एग्ज़ाम लिखने के बाद में हम लोग जब पास हो जाएंगे उसके बाद में वीज़ा प्रोसेसिंग कैसे होगी? क्या हमें
यस
जॉब सिक्योर करनी पड़ेगी, वो
यस
इंटर्नशिप
यस,
सिक्योर करनी पड़ेगी तब वो वीज़ा आएगा?
ठीक है।
सर
उसमें
इसमें थोड़ा बता दें।
वीजा मिलने का ऑस्ट्रेलिया में 3 पाथवे वहां पर। एक तो ये है कि वंस यू पास इस ओपरा एग्जाम, आप पीआर को अप्लाई करोगे अपना, आपको अगर मिल जाता है देन यू कैन गो ऑन पीआर वीजा इन ऑस्ट्रेलिया एंड देन यू कैन फाइंड ए जॉब इन ऑस्ट्रेलिया। ओके, सेकंड ऑप्शन ये है, यू कैन स्टार्ट लुकिंग ए जॉब एंड कंपनी, अगर आपको जॉब मिल जाती है तो फिर आपको कंपनी आपको वर्क वीजा दे सकती है। ओके, और तीसरा रूट ये होता है कि यू कैन गो ऑन स्टडी वीजा एंड यू कैन परस्यू योर ड्रीम। ओके, ये 3 पीआर वीजा, वर्क वीजा और स्टडी वीजा, ये 3 तरह के वीजा होते हैं ऑस्ट्रेलिया में।
सर पीआर में क्या क्या रिक्वायरमेंट रहेंगी?
ओनली क्या, या ओपरा एग्जाम अपने पास के लिए प्लस इंग्लिश, देन यू कैन अप्लाई।
जी, थैंक यू सर।
थैंक यू। नेक्स्ट ये और कोई रह गया?
सर इंग्लिश कॉम्पिटिटिव एग्जाम जो लिखना होता है वो मतलब कितने दिन तक वैलिड रहता?
2 साल।
2 साल, ओके।
ओपरा एग्जाम वैलिड रहेगा फॉर 3 इयर्स। इंग्लिश का जो स्कोर है वो रहेगा 2 साल तक वैलिड।
ओके, थैंक यू।
सर मास्टर के लिए ओपरा रिक्वायर्ड है या नहीं?
नो, अगर आपको मास्टर डिग्री करना है तो रिक्वायरमेंट नहीं है ओपरा की, बट इट डिपेंड को कौन सा कोर्स करना चाहते हो। अगर आपको एमफॉर्म करना है तो ओपरा नहीं देना पड़ेगा, बट इफ यू आर गोइंग फॉर एनी अदर कोर्स तो फिर आपको ओपरा देना पड़ेगा। बट हम आपका एडमिशन करा सकते हैं ऑस्ट्रेलिया में जिस भी यूनिवर्सिटी में आपको चाहिए, जिस जगह पर भी। तो प्लीज करें इन टच विद अस। तो अगर आपको स्टडी करना है तो अभी ऑस्ट्रेलिया में वी कैन हेल्प यू अपार्ट फ्रॉम ओपरा प्रिपरेशन।
ठीक है।
थैंक यू समीर। एंड नेक्स्ट, कुनैन अली, कैन यू प्लीज अनम्यूट? कुनैन अली, कैन यू प्लीज अनम्यूट? ओके गाइस, अभी किसी को कोई क्वेश्चन है तो प्लीज पूछ सकते हो अभी लास्ट।
सर मेरा एक और क्वेश्चन है।
यस सर।
सर कॉस्ट क्या होगी पूरी ओवरऑल प्रोसेस की?
देखो, वाट एवर जो कॉस्ट है ना, यू आर पेइंग टू द गवर्नमेंट। 80% फीस तुम गवर्नमेंट को दे रहे हो, हमको तो खाली ये कोर्स जो है उसका फीस
नहीं आपकी नहीं सर।
हाँ,
सर
टोटल
सॉरी
में
फॉर
वही रहा हूँ
इंटरप्टिंग सर।
क्योंकि गवर्नमेंट की
ओपरा
फीस
एग्जाम
होती
की
है। तो ओपरा एग्जाम को पहला होगा स्किल असेसमेंट, उसकी होती है 810 AUD। जब एग्जाम लिखोगे उसको होती है 2190 $21 से $90 होती है एग्जाम लिखने की। फिर इंग्लिश की फीस होती है ना, तो ये टोटल फीस बाय स्टेप आपको पे करना पड़ता है, बट ऑन एन एवरेज 5 to 7 लाख तक आपका टोटल खर्चा आ जाएगा।
सर आपकी कोचिंग मिला के या फिर एक्सक्लूड करके?
एवरीथिंग इंक्लूड, कैप कोचिंग, इंग्लिश का कोचिंग, आपका असेसमेंट, एवरीथिंग।
जी जी, थैंक यू सर।
Quran Ali, can you please unmute? तो एम फॉर्म में जिसको भी अगर एडमिशन चाहिए तो ऑस्ट्रेलिया में एनीवेयर इन द वर्ल्ड, आपको किसी भी कंट्री में जाकर स्टडी करना है, यूएस, यूके, ऑस्ट्रेलिया, कनाडा और गल्फ कंट्री में, तो वी कैन हेल्प यू इन योर एडमिशन। फ्री ऑफ कॉस्ट हम लोग आपका एडमिशन कराते हैं। जो फीस होगा यूनिवर्सिटी का वही आपको पे करना होगा, वो भी यूनिवर्सिटी के लिए, नॉट टू अस। ओके, तो प्लीज अगर किसी को, जैसे किसी ने शोएब का क्वेश्चन था, जैसे एम फॉर्म एडमिशन के लिए प्रोसीजर चाहिए, क्या चाहिए नो, तो एम फॉर्म अगर आपको करना है ऑस्ट्रेलिया में, तो यू नीड ओनली आपका इंग्लिश का टेस्ट पास करना है। उसमें अगर आपको 6.5 आए थे IELTS के अंदर, इक्विवेलेंट इन PT, एंड देन यू आर एलिजिबल। एंड एटलीस्ट मिनिमम 50% मार्क्स होने चाहिए आपके बी फॉर्म के अंदर। बी फॉर्म या आपने फॉर्म डी किया हुआ है इसके अंदर, दिस इज द ओनली रिक्वायरमेंट। एंड मैंने लिंक दिया हुआ है हमारे चैट बॉक्स में, ये हमारा व्हाट्सएप चैनल है, सो यू कैन कनेक्ट विद अस, एंड वहाँ पर हम लोग बहुत सारी न्यू इन्फॉर्मेशन डालते रहते हैं, जो भी आता रहता है अपडेट। Shoni, are you there?
Yes, sir, I'm here.
So I think we can finish here.
Right. Thank you, Nishta ma'am. Thank you, sir. Thank you guys for joining us today. And as you can see on the screen, once again, we are sharing the WhatsApp link so that you can.
Do you have any question or Quran Ali? You can ask.
Yeah. One question on the last. Years that we can purchase, we can pursue masters.
Clear nahi.
Sir, I just want to know that in Australia, do we have any informatic masters in informatics?
Yes.
And what are we costing?
Yes, मास्टर इन्फॉर्मेटिक्स है वहाँ पर। अब उसका यूनिवर्सिटी का फीस देखना पड़ेगा, बिकॉज इट इज नॉट ए वेरी कॉमन कोर्स, मुझे भी पता नहीं है फीस जनरली कितना है, बट जो भी फीस होगा हम आपको एडमिशन करा सकते हैं उसके अंदर, और जो फीस होगा यूनिवर्सिटी का वही आपको पे करना है। ग्रिफिथ यूनिवर्सिटी कराती है, तो आई विल नीड टू चेक द फीस एंड आई विल गेट बैक टू यू, आवर टीम विल गेट बैक टू यू बेसिकली। ओके सर।
And also for that, for this master also, do we need to go for this OPRA?
ये सर, आपको PR चाहिए तो भाई OPRA करना पड़ेगा, अगर नहीं करना है तो फिर अप टू यू।
Okay, all right, thank you.
देखो, वी आर हियर टू हेल्प यू टू कंप्लीट योर एंटायर प्रोसेस। मींस अगर आपको PR कैसे मिलनी है, परमानेंट जॉब कैसे मिलनी है, परमानेंट वीजा कैसे मिलना है, हम उसको टारगेट करते हैं। तो कौन सा राइट कोर्स रहेगा, राइट यूनिवर्सिटी कौन सी रहेगी, राइट कौन सा सिटी में आपको जाना चाहिए, वो सारा के सारा हम लोग आपको गाइड करेंगे। तो यू कैन गारंटी, और इफ यू वांट टू पास दिस OPRA एग्जाम एंड यू वांट टू गो ऑन PR वीजा, यू कैन। ओके, दोनों ऑप्शंस हैं आपके पास में। तो thank you so much for your time. We will get back to you. Our team will get to you one-on-one. So you can ask more questions if you have. So my advice to you, please note down your questions. So you can ask them one-on-one, whatever you have. They will call you on your phone. So even you can book a free VC. आप वीडियो बात कर सकते हो हमारी टीम के साथ में one-on-one 1 घंटे तक, तो उनसे वो फ्री में गाइडेंस देंगे आपके लिए। इन्हें अप टू यू, आपको ज्वाइन करना है नहीं करना, बाद में डिसाइड करो, बट यू अगर आपको इन्फॉर्मेशन चाहिए तो यू कैन टेक। ओके गाइस, थैंक यू सो मच फॉर योर टाइम एंड सी यू सून। बाय।
Thank you, everyone. Thank you, sir.
Thank you.